Yes, please
Yes,
start.
yes, sir.
Yeah. So good morning, everybody. Myself, Dr. Rishina here, and for the today's program, we have conveners with us, Dr. Gautam Chaudhary and Dr. Ramesh Sethia from the Rajasthan Urological Society. This program, as you know, was actually conceived as a part of the Raise and Rise initiative that has been started by the North Zone. Under this, we are doing various webinar activities. It may be student related activities, general urologist related activities, and these particular some type of activities are basically the activities that we do with the state associations, so that we are able to bring together all the states which fall under the zone in mutual respect and uh, the collaborative working with the states is increased. And we are also trying to reduce the physical workshops that we are doing. So in that regard, Rajasthan was one of the first states which actually um, uh, accepted the proposal of doing their annual conference as the midterm workshop. And as a regard to that, we are also reciprocating the same kind of a feeling, giving this particular platform to the Rajasthan Geological Society to come together with North Zone and do this scientific webinar. As related to the topic of webinar today, this is a very, I would say, very important topic in the sense that this is considered to be a field where the urologists think it falls in the purview of the gynecologist, and gynecologists similarly think that it falls in the purview of the urologist. So this is a kind of a field where both the specialities do not actually have that much of experience, and urogynecology as a field is now gaining importance because of that. And it is upon us to actually learn and uh, do the things properly in this particular field. And for this, we have very eminent faculty today. Dr. Aparna Hegde is there. She's a renowned urogynecologist doing only this field only. Dr. Shirikala Prasad, she's both a qualified urologist as well as a gynecologist. Dr. Deepak Dubey, Dr. Arvind is there, and many other faculty. We'll see Dr. Arun Chawla has also joined. So we'll see and learn from their experience today. So with this, I will hand over for the convener of today's program to Dr. Gautam Chaudhary. He is also the council member of North Zone. Dr. Gautam.
Good morning, respected seniors and dear colleagues. I would request to Mukesh Arya sir to just say a few opening remark words.
Good morning, Dr. Rishiner, Secretary, North Zone, and August audience. I welcome you all on behalf of Royal Urological Society. Cystocele prolapse and stress incontinence are common but under-discussed and underdiagnosed issues affecting physical, emotional, and social well-being of females. And it is vital for us to stay updated on the latest developments and treatment modalities. We are fortunate to have a panel of experts who will share their knowledge and insights on these conditions. Thank you.
Thank you, sir. So as sir mentioned that it is very common entity, though the very often discussed in a detail. So this is sir, and we discussed that we should have a topic where with the CTS sir and Arya sir, that we thought we should have a topic which is very relevant to the audience. So we chose this topic, and uh, this is very novel idea of the North Zone to reach every member of the North Zone, and in collaboration with the Rajasthan we are holding this webinar. So as you be progress in the webinar today, we'll see the all faculty members, they will present their best, and to discuss this topic in detail, we divided in three parts. So first we'll understand the pathophysiology of the topic, that is prolapse and the SUI relevant to the urologist, and second clinical part of that, and third, case-based discussion to, completely cover the topic. So for the first part, I would like to invite chairperson, and then chairpersons can invite the speakers. So chairpersons for first part are Dr. Ashok Sharma from Kota, Dr. Arjun Singh Sandhu, head of the department AIMS Jodhpur from Jodhpur, Dr. Nilesh Jain, head of the department Medical College Kota, uh, Dr. Sunil Gokru, head of the department from the R&D Medical College Udaipur, and Dr. Ilyas Sharma. So hand over to you. Please call upon the speaker and then we start.
Dr. Ashok is actually suffering from fever. He just messaged me.
No problem.
You can call the sir. We will start with the program, and then the chairpersons can take over in between.
Okay.
Ask Dr. Dr. Sandhu
okay, so,
to continue.
Yeah.
Dr. Gokru
So
is there.
or else.
Dr. Sandhu is...
So I will call upon Dr. Manish Gupta from the Jaipur to start the first presentation. He will be speaking on the functional anatomy and the pathophysiology of the prolapse and the SUI. Manish sir.
Hello. Good morning, Dr. Chaudhary, Dr. Sethia ji. Good morning. You have assigned me to speak about this topic on female functional anatomy and pathophysiology of female prolapse in females. So it is a very the anatomy of the female pelvis, and it's very complex. But I have tried to. Can you listen me?
Yes.
Hello.
Yes, sir. Clear.
And the slides are. You can see the slides.
No.
Not yet.
Not yet. Just a minute. My slides are not visible, so how can share कैसे करेंगे?
Please share your screen, Manish.
Can you see me on the screen?
Yeah, we can see you, not your screen.
Screen, no.
So you have to share the screen.
Okay, I'm just trying.
Okay.
Share the screen. Okay.
Yes, now we can. Yes.
So this is a functional anatomy and pathophysiology of pelvic prolapse in female. So as we all know, it is a very any downward displacement of one or more pelvic organ like uterus, vaginal apex, urinary bladder, rectum, and associated vaginal segment is comes under the definition of prolapse. Let us begin with the bony pelvis, anatomy of the bony pelvis. The female pelvis is divided by an oblique line passing from the sacral promontory posterior to the. Can we remove this? To the superior margin of the pubic symphysis, corresponding to the iliopectineal line, into true pelvis and false pelvis. The true pelvis is the area below the pelvic brim, and the false pelvis is located above the pelvic brim. The pelvic brim defines the pelvic inlet. So in this figure, we can see the bony pelvis. The line, the iliopectineal line is the sacral, the line passing, arbitrary line passing from the sacral promontory to the pubic symphysis. And the area above this line is false pelvis, and the area below this is a true pelvis. The true pelvis has 4 bones, 2 hip bones or innominate bones constituting of ilium, ischium, pubis, sacrum, and coccyx. In this figure, we can see the line. This is the iliopectineal line. Okay, and this is the false pelvis above this line, sacral promontory, and the iliopectineal line. Next. Now comes the facial parts. We divide into 3 strata: inner strata, intermediate strata, and outer strata. The outer strata is constituted by the transversus fascia and iliac fascia. The transversus fascia is continuous with the endopelvic fascia and lateral pelvic fascia. Iliac fascia covers the iliac muscles. And similarly, the intermediate facial part, it surrounds the uterus and corresponding vessels. The retroperitoneal connective tissue, pubovesical and pubocervical fascia, they support to the pelvic organs. The innermost facial layer is named by rectus fascia cover that covers the anterior and lateral rectal wall, vessels, nerves forming a part of denovular fascia. In the diagram, we can see cut section. The bladder, uterus, they are supported by all the fascias. See, there's the pubocervical ligament and ligament of fascia. Okay, next, please. The endopelvic fascia extends down from the uterine artery to the fusion of vaginal and levator ani. Arcus tendinis fascia pelvis. It is a thickened band of pelvic fascia running from ischial spine to the pubic bone. The key point, it's a key point for facial layer attachment. Muscles of the levator ani attached to it. It arises from the pubic bone laterally, pubovesical ligaments medially, and the tendinous arch of the levator ani.
You lost the connection.
Vesical space.
Dr. Manish, you can switch off your video maybe. That will improve the connectivity. Hello. Has he got locked out?
I think connection.
Dr. Manish, no, he's there. I just saw. Dr. Manish, you can switch off your own video. Just let these slides running, so we'll be able to hear you better. You can see your slides. Unmute yourself and then.
Manish sir,
Yeah,
can you
am
hear
I
us?
audible?
Yes,
Yeah,
yes,
yeah, I can
please
hear
go
you.
ahead.
So we were discussing about the 6 spaces, the vesicovaginal space between the bladder and the space and
You can
pre-vesical space.
switch off your own video and let only the slides running. Okay?
Just a minute.
That will help in an uninterrupted.
Yes, better now.
Now, my slides are, you can see my slides?
Yes, sir. Please go ahead.
Okay. The other spaces are retrorectal space between the rectal fascia and transversus fascia over the sacrum, paravesical space, and pararectal spaces. Next. Now comes the pouches. The rectouterine pouch or pouch of Douglas is formed by the fold of peritoneum. It extends between the uterus and rectum, bound by uterus posteriorly and posterior vaginal fold, holding rectum and uterosacral ligament. Then vesicouterine pouch is demarcated by uterovesical fold, uterosacral fold between the pararectal and paravesical fossa. This is our rectouterine pouch, and this is the superior uterovesical pouch. A few words about the ligaments. The important ligament are sacrospinal ligament, sacrotuberous ligament. They are very important ligaments of the female pelvis or any pelvis. The sacrospinous ligament attaches from the ischial spine to lateral border of the sacrum. Coccyx muscle lies over it. Coccygeus muscle. Sciatic nerve and plexus cover the coccygeus muscle. Must be avoided during board suspension. Sacrotuberous ligament runs from posterior iliac spine along the sacral border and attaches to the ischial tuberosity. Attaches the ilium and ischium to the sacrum. Greater and lesser sciatic foramen runs above and below the sacrotuberous ligament. In this, we see the various ligaments. One of the important ligaments is transverse cervical ligament or the cardinal ligaments. Just a minute. These are all ligamentous attachments. Sacrospinal ligament lies in continuity with the sacrococcygeal ligament. Pubovesical, vasicopelvic, cardinal, and uterosacral ligaments and pubocervical fascia are condensation of transversus fascia. It helps support the pelvic organs. Pubovesical ligaments or pubourethral ligaments is analogous to the male puboprostatic ligament. It runs from the pubic bone to the bladder neck, provides a retropubic suspension, holds bladder neck in place, provides support for the mid-urethra in continuity with the anterior vaginal wall. Perivesical and endopelvic fascia fuse to form vasicopelvic ligament or fascia. It extends from the base of the bladder and anterior vaginal wall, attaches to the tendinous arch, continues with the periurethral fascia, cervix, and cardinal ligaments. Defects in it can result in lateral cystocele defect. So here we can see all important ligamentous attachments. This pubocervical ligament. This is cardinal ligament and uterosacral ligaments. They are important during the time of hysterectomy performed by our gynecological colleagues. So we should take care of all these three ligaments for the integrity of the pelvic wall. Then comes broad ligament, formed by the peritoneum, extending from anterior and posterior surface of the uterus, contains fallopian tube and ovary, lies in the posterior lateral surface of the uterus, attaching to its pelvic wall. Uterine artery, vein, nerves lies within the broad ligament. Round ligament exits the internal inguinal ring, crosses over the external iliac artery, terminating in the mons pubis of the labius majus, attaches the lateral uterine body wall to the pelvic side walls and contains the ovarian ligaments. Then comes the infundibular pelvic ligament or suspensory ligament of the ovary. It lies behind the broad ligament, runs from ovary to lateral surface of the uterus. Okay. Cardinal ligaments and uterosacral ligaments lie within the parametrium. Blood vessels, nerves, smooth muscle, adipose, and connective tissue lie near these ligaments. These structures are at risk during hysterectomy and can lead to bladder dysfunction. The ureter lies lateral to the anterior portion of the uterosacral ligament, closest at the cervix. Risk for sacral nerve entrapment, S1 and S2 to S4 nerve trunks are there. The cardinal ligaments fuse posteriorly with uterosacral ligament. It stabilizes the uterus, cervix, and upper vagina. Originates from S2 to S4. It inserts into the posterolateral aspect of the pericervical fascia and lateral vaginal wall. It contains major blood vessels. Ureter is susceptible to injuries as it passes near the ligaments. Pelvic side walls are formed by the muscles like obturator internus muscle, iliacus muscle, psoas major and minor, levator and eye complex, and coccygeus. The obturator internal muscle covers most of the lateral pelvic side walls, passes through the lateral sciatic foramen, attaches to the greater trochanter of the femur. Okay, this is the diagram showing major part formed by the levator and eye complex. In the pelvic floor is composed of pelvic diaphragm. It extends from the pubis anteriorly to the coccyx posterior. The pubococcygeus, puborectalis, and ileococcygeus. Puborectalis is also sometimes called pubovaginalis muscles. Levator and eye forms the greatest part of the pelvic cavity.
Randy sir,
Yes, yes, Gautam
can you
ji.
wind up? Yeah, can you wind up?
Yeah,
Because we're exceeding 10 minutes.
within give me 2 minutes. Okay. So in nutshell, we have discussed about the ligaments, pelvic. These are various parts of the levator and muscles. I know this is a very boring topic. The anatomy is very difficult here. During descent of the pelvic organs, these three levels are always taken in consideration. Level 1 is the cervix and the upper 1/3 of the vagina. Level 2, there is mid portion of the vagina, and level 3 is most caudal region of the vagina. Let's go. So level 1 is suspend the uterus in upper vagina to sacrum and lateral pelvic wall, composed of the parametrium, and the most important here is the formed by the uterosacral ligament and the cardinal ligaments. It suspends it is very important during the descent, because whenever there is injury of this area, then there is level 1 type of descent, and loss of level 1 support contributes to prolapse the uterus and vaginal effects. Level 2 includes the paravaginal attachment to the middle third of the vagina. The arcus tendinous fascia pelvis is the band of the connective tissue attached to this. So whenever there is injury to the arcus tendinous, there is the level 2 type of descent is there. The level 3. So whenever there is cystocele, so cystocele and the anterior vaginal wall prolapse is due to the injury to the level 2 support. So level 2 support is mainly the arcus tendinous and the fascia formed around the arcus tendons. The level 3 is the distal vagina. At this level, the perineal membrane is the layer of connective tissue. Whenever there is a injury to the perineal membrane or its connective tissue, there is a level 3 type of descent where there is a formation of rectocele and perineal descent. So in all three type level of descent, the anterior vaginal wall prolapse is known as cystocele, posterior vaginal wall is rectocele, and prolapse there is uterine prolapse vaginal wall enterocele. We'll not discuss here. The causes of the descent is inborn weakness of the support system and acquired where there is a levator and eye muscle weakness or ligament injury or nerve injury, pudendal injury, endopelvic facial weakness, and perineal body weakness. As we all know, multifactorial, there is the risk factors. Vaginal delivery is the most important factor. Advancing age is also important factor, as we all know. With the obesity, hysterectomy, and race also. So less prevalence is seen in the black females and highest prevalence in the Hispanic women. Other risk factors are menopause, genetic predisposition, prior pelvic surgery, connective tissue disorders, increasing intraabdominal pressure, chronic constipation, straining. So we all know levator ani muscle is an important component of pelvic organ prolapse. Portion of the levator hiatus ventral to the perineal body or urogenital hiatus. Through it occurs prolapse of the vagina, uterus, and bladder. It is kept closed by tonic activity of the levator ani muscles. So let us wind up quickly. So most importantly, vaginal delivery contributes to the pelvic organ prolapse through levator ani muscle injury. Next. As we all know, endopelvic facial ligaments can be or stretched during vaginal delivery, hysterectomy, chronic straining with aging. And failure of ligamentous attachments can occur due to altered collagen metabolism leading to prolapse. This alteration and the alteration of the ratio of collagen type 1 and 2, 1 and 3 could also lead to pelvic organ floor dysfunction. Can also occur due to pudendal nerve injury and nerves to levator ani muscles. And so we all know the important part of the pelvis is the fascia, muscles, the anatomical structure of the female pelvis, and it's a very complex anatomy of the female pelvis. So, in a nutshell, we have. I think we have discussed everything here. Thank you, Dr. Gautam.
Thank you, sir. I request all the speakers and to be on time because we need to finish on time. And chairpersons, please, they
If there are
can
any questions, the
interact.
chairpersons can take over and the interaction going. Yeah.
Can I introduce the next speaker?
Yeah, sure, sir.
So the next topic for discussion is voiding dysfunction and incontinence in prolapse / cystocele. So by Dr. Arvind Panda from Hyderabad. So I'll request Dr. Arvind Panda to please present his paper.
Thank you so much, sir. It's a great pleasure to be here. I'm really grateful to NZUSI and Dr. Rishi for kindly having me here. And I'll go directly to the presentation. Just a second, sir. Yeah. I hope you're able to see my slides.
Yes, sir.
Yeah.
Very well.
Why do this? Okay. So pelvic organ prolapse refers to the protrusion of the pelvic organ beyond its normal anatomical confines. And this we will find in certain, in almost 50% of all Paras women, those who undergo a vaginal delivery. I'll try to be simple here because we are urologists more than gynecologists. If you look at the pelvic floor, traditionally we divide that into 3 compartments. There is the anterior compartment with bladder and urethra, the middle with the uterus and the vagina, and the posterior compartment containing the anorectum. This is a very simplified version of doing it. Okay, the next. Okay. So what happens if there is a weakness of the pelvic floor? I won't go into anatomical details. Already it has been explained by the previous speaker. So both the proximal urethra and the bladder neck descend and rotate around the pubic bone, initially moving posterior inferior, as you can see in the MCUG. That is funneling of the proximal urethra, and then kinking of the urethra at the uretrovesical junctions, particularly in large cystoceles. And what happens, because that urogenital hiatus is of limited space, sometimes a very large cystocele can block the prolapse of other pelvic structures and therefore mask a rectocele or an enterocele, which will be unmasked after you have corrected that cystocele. So these are some things that we need to know. So again, continuing with this classification system, so anterior compartment prolapse mostly is the cystocele, the middle compartment uterus and vagina, and posterior compartment mostly we see rectoceles, and they are not very symptomatic in terms of the urinary symptoms. They may have urinary incontinence, they may have fecal incontinence, but not in terms of urinary symptoms. So how do you evaluate this patient? Take a history, take a bladder diary, do a good physical examination, check for bladder fullness. Very important. Sometimes these patients may be obstructed because of the kinking of the urethrovesical junction. Do always a focused neurological examination for perineal sensation, bulbar cavernous reflux, anal reflux. Then a good pelvic examination. Do it in the lithotomy position, characterize the extent and the compartments involved, put a nice speculum, particularly with anterior and posterior openings, and look at the apical descent during the Valsalva maneuver, do a staging, a POPQ staging if possible. And at this point of time, do a stress test for stress incontinence after reducing the prolapse. Reduce the prolapse and see if there is a significant stress incontinence. Always remember to do a blood work, including a renal function test and ultrasound for the kidneys and for the post-void residual urine. Uroflowmetry is absolutely important. Do it without reduction. And then if it's a significant prolapse, 3-4 prolapse, do it with a pessary in situ to see if the flow improves, particularly if the flow has been bad the first time around. If the flow is good, you don't need to do this second step. If the flow with and without the pessary is inconclusive and the PVR remains high, this is indication for MCUG. And not only that, if you are suspecting underactive detrusor and for possible prognostication, you may, in your clinical judgment, with the pessary in situ, do aerodynamic testing. This is basically to assess for underactive detrusor, because these patients may have suboptimal flow in a small percentage, even after the pelvic organ prolapse repair. And remember to any additional incontinence procedure in these patients, apart from the pelvic organ prolapse, is actually contraindicated. This is something we need to remember. So I have tried to make it simple and sort of divide the type of voiding dysfunction that we see with cystoceles and prolapse. One is, of course, underactive detrusor, that is cystocele. So there are two very nice papers. This paper was published in 2011, examined voiding dynamics in women with high stress, with stress urinary incontinence and high state cystocele. So they had about 57 patients with SCY and 47 patients with high state cystocele. What they found is very interesting, that the patient with the large cystocele, even after correction of the cystocele of the vaginal pessary, they had a low maximum urinary flow rate, a low detrusor pressure during maturation, then the controls and those with stress urinary incontinence alone, and a maximum Watts factor and a bladder contractility index. These were also significantly low. That you can see in this 47 patient, this table 1, many were cystocele alone, some had cysto and rectocele, some had cystocele, rectocele, and uterine prolapse. In fact, the largest component had cystocele, rectocele, and uterine prolapse. And these are the patients who actually had an increased prevalence of detrusor underactivity. So they hypothesized that chronically decreased or increased urethral resistance may alter voiding dynamics and performance. In the second paper, this is in 2017, where they evaluated detrusor underactivity in pelvic organ prolapse. So they had 518 patients, and the detrusor underactivity was identified by the bladder contractility index. And they identified that almost 41% of patients in the POP group had detrusor underactivity. And these patients had higher rates of voiding symptoms, almost 60%, higher rates of higher PVR more than 100 ml, and lower rates of urge incontinence and detrusor overactivity because of detrusor, these patients. And what they found is, after they operated on these patients, the post-operative voiding symptoms improved, and to be comparable with the group without detrusor underactivity. So to conclude, they concluded that obstruction removal may recover detrusor underactivity in many of these patients. This is a very significant finding. The second thing you must remember is, what about stress urinary incontinence with prolapse? It's something we see very commonly. So it is present in 80% of moderate to severe prolapse, grade 2 and 4, mostly occult. Remember, this is important, mostly occult, that you will not be able to find in 60% of the cases that there's actually a stress urinary incontinence along with this prolapse. In a small percentage, it's overt. The management of this overt group is far more simpler. Why does this happen? Why is this mostly occult? Because the apparent continence is due to kinking or compression of the urethra, and this continence is removed by the prolapse reduction. So the unmasking of the stress leak occurs after prolapse correction, and this will occur in 30 to 80% of clinically continent patients with higher degree of prolapse. So this is a paper from India, where 78 continence patients with 3 and stage 4 pelvic organ prolapse, they repositioned the prolapse of the pessary, subjected to 1 hour pad test, and 62% had occult USI. So Dr. Kekre concluded that 46%, 44% of these patients, after they did hysterectomy and pelvic floor repair, will have a symptomatic SUI. It's a very significant paper. So what should we do? Then because of this, there is this case for something called the pessary trial. Pessary will simulate a surgical repair. So it can prognosticate regarding avoiding difficulties and overactive bladder. Overactive bladder is a little tricky. I'll come to it later. So why? Because the stress urinary incontinence, which has missed after clinical examination, is in 19% of patients. So even if you do a good clinical examination, you reduce and ask them to cough, they may not show stress incontinence. You put a pessary, it may be in another 20%, you will actually get incontinence. Some patients present to you with pelvic organ prolapse and retention. Can you prognosticate that after you repair that prolapse, will she void? Yes. If you put a pessary in situ, you can predict with sensitivity of 89% and a specificity of 80% whether the patient will actually void after the correction of the prolapse. And of course, they already discussed this occult stress urinary incontinence, 60-70% of patients with grade 2 or grade 4 prolapse. So how do you do this? You must provide a pessary to the lady after evaluation and then re-evaluate after 1 week for the resolution of symptoms if they have occurred. It's very important to find the correct fit of pessary. Generally, a size 3 or 4 is used. Find a correct fit, find the correct type of pessary, ring versus gel-on you can choose, and then put it properly. What about doing a simultaneous anti-incontinence procedure with the repair? Now, those who, as I said, they have symptomatic SUI, it's not a problem. So you go ahead and say give them the option of simultaneous anti-incontinence procedure. So it obviates the need for a future SUI surgery. And the number needed to treat also is very good, 2.5. This is excellent. But what about those with occult SUI? They really don't have SUI. They'll say, doctor, I don't leak. I just come for the prolapse. So these are the patients who do not readily accept a prophylactic procedure. But even here, a concomitant prophylactic midurethral sling will reduce development of SUI 5% to 40% and the risk of a second surgery of SUI. This is something we need to explain to the patient that these are the figures you can choose. But when you do a concomitant anti-incontinence procedure, remember that you do it with a sling that is a separate incision from the colporaphy incision. Because if the incision does cross the bladder neck, the chance of sling migration is quite high. So better do it a separate incision.
Dr. Panda, could you please wind up?
Yes. So what about bladder obstruction? So this is a lady, 69-year-old lady. So you can see she had a presidentia and she had renal function obstruction of the outlet because of this thing. So in this, if you put a ring, we actually put a ring, it improved. So again, for the last 2 slides, what can happen after definitive management? Just remember this last line that in detrusor underactivity, avoid additional anti-incontinence procedure because they will go into retention after that. The last, most important thing, and the last thing is after you do reconstructive surgery, there are incidents of new onset urge incontinence pelvic symptoms. And these are most importantly de novo detrusor instability. This is something you can't really predict before you do the surgery. So this is the cause of most common cause for patient dissatisfaction 1 year after surgery of this new onset urge incontinence. This is very difficult to predict pre-surgery. So to conclude, the incidence of bladder obstruction and voiding dysfunction is significantly higher with higher degrees and more severe degrees of prolapse. And there's a direct association between the severity and its prevalence. Trial with a vaginal pessary insertion is invaluable. In inconclusive cases, do a video aerodynamics. It can rule out other causes of voiding dysfunction. Prolapse repair causes significant relief of obstructive voiding symptoms and detrusor underactivity, but to a lesser extent storage symptoms, which can occur also de novo. Thank you so much.
Chairpersons, I request chairpersons to ask questions which are in the chat box to the speakers.
Sir, please unmute here.
So coming to yes, can you hear me?
Yes, sir. Yes, sir. Very well.
Yes, sir. So the first question is the role of levator muscles in incontinence. So I'll put this question to Dr. Manish Gupta, please. Dr. Manish?
Is he
I
there?
think
Logged up.
If Dr. Manish is not there, then I'll request Dr. Arvind Panda to please answer this question.
Sir, could you repeat the question, sir?
The role of the levator muscles in incontinence.
Yes, sir. Actually, sir, most of these patients, the pelvic floor, the entire pelvic floor is a structure that is formed by these levator muscles, most of the levator muscles. What happens when they get weak? That generally happens after childbirth, after vaginal delivery, and also with age. Just not vaginal delivery, with age, there's a degree of laxity. And when that happens, depending on where the weakness is, you can have anterior or a middle or a posterior compartment weakness. So that is definitely a contributory factor. Difficult to say exactly how much it contributes in any individual case.
Yes, thank you. The second question is, can we clinically differentiate primary detrusor underactivity from secondary detrusor underactivity, and does it even matter clinically?
So it matters in the sense you have to prognosticate. You are going to operate on a patient, and when you're going to operate on a patient, you need to be telling that if you have detrusor underactivity and you do incontinence procedure, the patient will have may not void or have voiding dysfunction after the surgery. Just prior to the surgery, the patient was voiding well, even though there was a prolapse. So in that sense, it is important for us to differentiate. The second point is primary, secondary. That is very difficult to say. Which is primary, which is secondary. Most of these are secondary to the obstruction. So that is a chance you'll have to take to exactly delineate that, okay, this is primary, this is secondary, would be very difficult.
Thank you. You had mentioned about the pessary test. So Dr.
At least a
Anurag
week, sir.
Singla,
At least a
Can
week
you
you need to, at least a week you need to give. And it's very important to find correct size and make sure that the patient retains the pessary. That is also important. So counseling is required in this. Get a correct size and at least a week to know whether the symptoms have improved.
Okay. Thank you. There's another question from Dr. Mayank Agarwal. So the question is that secondary detrusor underactivity is not uncommonly caused by pelvic floor spasm, stroke EUST, which is treatable. This is a comment. So I'll go to the next question. How should one assess with pessary or for occult stress incontinence? Which pessary and for how long?
Sir, again, sir, you need to size it. Normally, size 4 is the standard size. It can be bigger, it can be less. And the most important thing is you can help to take the help of a gynecological colleague. When you do a PV and you have to check the distance between the middle finger and the index finger and then size the pessary. And once you put the correct size pessary, it should unfold and hold up the cervix. This is best done with the help of a gynecological colleague who has been applying pessaries for a long time. So that is something, as I have said, this is something which will benefit from a sort of multidisciplinary management. Correct pessary, correct size at least a week.
Yes, thank you. Last question from Dr. Sudhir Kumar Divana. How do you go about when you have mixed incontinence along with pelvic organ prolapse?
So this is something, sir, you will go ahead with the repair after counseling the patient. Just make sure, because many of these, and if you have a stress leak at the same time, you go with the repair, and then many of these actually improve. It is a very small percentage will have a more severe, as I've said, 5%, 5 to 7% of these patients will have a more severe urge leak. So this is something which you need to explain to the patient, go ahead with the repair. And if there is a urge leak in this 5 to 7%, we can treat. We have the drugs to treat. The thing is, I did not find any evidence or literature to how long will you need to continue with this urge, with the medications for urge leak and when it's going to be resolved. Some degree of urge leak is expected because of the long-term outlet obstruction and the detrusor instability that should ideally resolve in 6 months to a year. But exactly how long we have to treat, I did not find much evidence.
Thank you very much. And thanks a lot to everybody, the organizers, the speakers and participants. Thank you very much.
Thank you, sir.
Thank you, speakers and the chairperson, for the first set of the talk. So let me start the second part of the understanding of the prolapse, in which we have three speakers. They are going to speak on the relevant topic. So I would like to call upon the chairpersons for this session, Dr. Vishwas Baheti from Udaipur, Dr. Ritesh Mehta from Jaipur, Dr. Achal Gupta again from Jaipur, Dr. Anurag Yadav from Agra, and Dr. Atul Mittal. Please go ahead, and I request again to speakers stick to the time, please. So we finish on time.
Chairperson.
So one of the chairperson can introduce the next speaker.
Can you hear me?
Yes, yes.
Yes, yes.
Okay. So our next speaker is Dr. Uday Singh Beniwal.
No, Madam Shrikala Prasad is there.
No. First is office evaluation for prolapse.
Okay. All right. Sorry.
So I request Ma'am Srikala Prasad from Chennai to speak upon office evaluation of the prolapse with or without concomitant SUI. Ma'am, please.
Ma'am, please
Good morning. Good morning. Thanks to the entire North Zone USI and Dr. Rishi and the entire team. Am I audible?
Yes, ma'am.
Okay. So, this is on office evaluation of the prolapse with or without SUI. Briefly on physical history, physical examination, investigations, and other imaging. So, what are the common symptomatology? They come with mass descending per vaginum, bulge in the vagina. So, basically, bladder, bowel, sexual symptoms, and the prolapse. These are the four main domains. So, I spoke of mass descending. Bowel symptoms, constipation is a very important aspect. It can be either a cause or the effect also. We are more concerned about the urinary problems. We heard Dr. Panda talk about the voiding dysfunction, so they can have difficulty in passing urine, and because of the obstruction and residual urine, they can have recurrent UTI, increased urinary frequency, urgency, urge incontinence, stress urinary incontinence, and a lot of the stasis can also lead to stone formation. Sexual symptoms are a little underplayed symptoms, but especially since many of these people are the menopausal age group, they have those menopausal symptoms as well, can complain of pain during sex, dryness also. So when we talk of mass descending per vaginum, it can be a cystocele, vault prolapse, or the entire pelvic organ prolapse, a suburethral cyst, or a urethral diverticulum. You can have varying presentations of this pelvic organ prolapse. The common complaint is it increases on straining, coughing, and doing heavy work, and it can be reducible. Usually, in the initial stages, it is usually reducible. And in the initial stages, it is associated with low back pain, which is a result of the uterosacral ligament strain, which is typically worse at the end of the day and relieved with rest. They also do complain of difficulty in walking. It can be a global prolapse like rectal prolapse associated also. Urinary complaint, as I was telling, they can be associated with difficulty in passing urine. And the very typical symptom is the more they strain, the more is the difficulty. Because you can see the prolapse coming out and causing urethral kinking, and it causes difficulty in passing urine. So how do the patients help themselves? They do what is called splinting, put two fingers inside and reduce, like what we do in a pestle. So this pelvic organ prolapse can cause sense of incomplete emptying, stasis, so increased residual urine and urinary tract infection. Very rarely in long irreducible prolapse, we have seen patients coming with even creatinine of 6 or 8. So because of the back pressure changes and damage to the kidneys. So this irreducible prolapse, I was talking, can has multiple bladder stones, and this bladder outlet obstruction can lead to obstructive uropathy, decubitus ulcers, etc. Here, this is, I just put this to show decubitus ulcer will normally be here. So this was a malignancy on the vaginal wall. So to us, they come with urgency and urgent continence. So even though it is a case of prolapse in uterus, we have to think of all causes which can cause increased frequency and urgency. All those causes have to be looked in. India is a diabetic capital of the world. We must not forget diabetes, urinary tract infection, vesical calculi, etc. One nice thing is this cystocele correction, definitely we see it decreases the increased frequency and urgency. Dr. Panda was showing us statistics as to how there can be de novo symptoms, but they are very less. By and large, most of them, it becomes better. We don't have to promise them cure from urgency and urgent continence, but we can tell that mostly it comes down. So while you examine a case of SUI, the ideal thing is we have to examine in a comfortably full bladder, reduce the prolapse and look for occult SUI. How do we reduce? We can reduce with the swab, we can reduce with 2 fingers or put in a pessary. Again, this was told earlier, the urethral kinking associated with pelvic organ prolapse will mask the stress urinary incontinence. So that is why we reduce the prolapse and then look for any occult incontinence. Clinically, we can also look whether there is urethral hypermobility with coughing or Valsalva, whether there is mobility. We don't do this Q-tip test, but you can easily visualize and see. Or is there a fixed immobile urethra, which is a marker of intrinsic sphincter deficiency? Another important clinical test is, so in prolapse, I always tell, examine the patient in a full bladder, where you reduce and look for SUI also. Similarly, in an empty bladder also, you examine her. If the patient has leak, even in an empty bladder, again, it is a marker of intrinsic sphincter deficiency. So prolapse, full bladder examination, empty bladder examination, examination with the prolapse outside as well in the reduced position. Other history, all of us know, obstetric, menstrual, gynec, surgical, personal and drug history. So a complete examination, including a general examination, a focused urological and a gynecological examination. Look for any mass. A palpable mass can even be a distended bladder because we know they can have an obstructive voiding pattern. It could be any other mass lesion. Look for any scars of previous surgery. And I will also talk about the pelvic organ prolapse quantification. So look for cystocele, rectocele, the size of the uterus, adnexal mass, the vulva, perineal body, urethral assessment, stress urinary incontinence, and also assess if there is any menopausal changes. And if the vagina is totally atrophic, it is ideal to correct the atrophic changes with topical estrogen before we take up for surgery. So here I'm just showing, this is not new to, no, it is not. I was just showing a demonstration of the stress incontinence. It's not playing. And now we will go to POPQ. POPQ is a little theory before I show the video. Numbers are derived with the reference point, hymen, the vulval outlet, or the hymen is the landmark. Inside are given negative points and outside are given positive points. We can use a ruler or even a urethral catheter, or there is a marker, sterile marker device available, or in the air spatula, you can mark it with 1 centimeter as a single hash, and in a 5 centimeter, you can put a double hash. This is the grid AA, BA, C. I will talk about each individually. While you measure the POPQ, total vaginal length is different from others as it is measured in a relaxed position without Valsalva, whereas TVL, GH are just numbers. So it may look initially tough, but simply I'm just telling the theory now and I will show a video. Point C denotes the cervix or the cuff in hysterectomized patient. So you ask the patient to strain and see where the cervix comes in relation to the hymen. A. So you will have A, B, B. So what is point A? Capital A. Capital A is a set point which is 3 centimeter inside the vaginal wall. And if this capital A is inside in the anterior wall, it is AA. which marks the urethrovesical junction. If this 3 centimeter inside the vaginal wall posteriorly, you call it AP, and that denotes the anorectal junction. You can actually mark that point with the marker and then ask the patient to strain and see where that point comes. In a perfect score is, that is, there is no prolapse, both AA and AP will be -3. How much ever the prolapse is, maximum it can come only to +3, because we are only seeing where that -3 comes to. So mark point AA on the urethrovesical junction. That is the anterior vaginal wall. That capital A is a set point which is 3 centimeter from the hymen on the anteriorly. That is the urethrovesical joint. You can mark it and ask the patient to strain and see where it comes in relation to the hymen. I'm again going to show a video. So this is just for a theory. So however big the procedentia is, the maximum measurement will be only +3, because we are only seeing where that we had earlier marked 3 centimeter inside the hymen, where that is going to come. Similarly, the total vaginal length, this one point is only we will measure when it is fully reduced. There is no valsalva, you have repositioned it, which is the total vaginal length. It can be 8, 9 or 10 centimeter. It allows the depth of the prolapse to be assessed and reassessed after surgery. So how does it actually help? If the total vaginal length is very small, you cannot do a sacrospinous colpo suspension because you cannot tie it and go in. So it's better to go for an abdominal sacrocolpopexy or a high uterosacral ligation. Genital hiatus is measured from the middle of the external urinary meatus to the posterior fauciate in the midline. Wide genital hiatus means the levator is defective. Perineal body is measured from the posterior fauciate in the midline to the midanal point. It assesses the tonicity of the superficial pelvic floor. Now we are going to see the point B. So how to remember point A and point B? Point A is a set point. Point B, see, when you compare between A and B, you know B is bad. So B represents the worst prolapse in the particular segment. So if you put capital B, you're going to assess which is the worst or the most dependent. If that worst point is in the anterior vaginal wall, you call it capital B and small a. So retract the posterior wall and then ask the patient to strain. Now check where is the most dependent portion of the anterior vaginal wall. Similarly for the posterior vaginal wall. And what is point D? Point D represents the highest point of the vagina. It represents the posterior cul-de-sac, and it is attachment of the uterosacral ligaments. So here you will know whether it is an elongated cervix or a prolapse. In an elongated cervix, you will have the uterus will be well suspended, whereas in a post-hysterectomy or it's a prolapse, it may come out. So D is important in knowing if cervix is long. Point D, when compared to C, will differentiate a prolapse from elongation of the cervix. For example, if it is only a elongated cervix, again this D will be inside, whereas the C will come out nicely. And in hysterectomized patient, it is not applicable. Again, here we stage 1, 2, 3, and 4. In earlier Shaw's classification, just below the ischial spine used to say 1, at the introitus 2, outside the introitus is 3, and totally out it is 4. Here, the same, just a little modification. Stage 1, if it is just below the ischial spine, but how much below? It should be within. See that -1 to +1 is stage 2. So it should be little above the -1, that is 1. -1 to +1 is 2. Above, outside the introitus, more than 1 centimeter outside the introitus is 3, and it is more than outside the introitus, but within TVL -2 is stage 4. I'll again show in the video. You will be able to understand it. So I'll just try to play this video. Is it audible? Hello?
No, ma'am, no.
Ma'am, not audible. We can see the video.
No. I'll just 1 second.
So when you share the video, click on the share sound also.
Yeah. Just 1 minute. External urinary meatus to the midpoint of the fourchette.
Have you got it?
These are the 9 points on the POPQ grid. So to make things, it may look very complicated in the initial, but we can make it very simple. So I'm now starting with simple measurements. So let us start with the middle row, the GH. First I'm going to measure. The GH is from the external urinary meatus to the midpoint of the fourchette. Can you see? So it is around how much? 6 centimeter. Can you see? From the external urinary meatus to the fourchette posteriorly, the midpoint. So maybe 5.5 to 6. Okay. So right. Then PB, midpoint of the fourchette to the posterior to the medianal point. So that is 1, 2, 3 centimeter. Okay. And TVL. TVL is a point where we don't ask them to strain. So now she is well relaxed. I am putting it inside nicely, as deep as possible. We are just measuring the total vaginal length. Okay. So can you see? You have the double hash. Are you able to see? 10 centimeter. From the inside till here, you are able to get a 10 centimeter. That is the, so middle line is over. So 1/3 of our POPQ grid is over. The next is, now we want to know point AA. A is a point, set point, which is 3 centimeter from the meatus in inner aspect. So normally a cervix in a person without a prolapse, it is going to be like this. So it is from 3 centimeter anteriorly, you have to mark inside. So if you mark, it will be this point. So this, you know, from here, from the meatus, it comes to this point is -3. That is the one which is normally without, in a patient without prolapse. So that point is called AA. AA is a point 3 centimeter from the hymen on the inner aspect. Now you have to ask her to strain and see where that comes. Ma nalla mukkunga. Yes. Now you can see that it comes almost, it is fully out. So maximum, can you see? So from here it comes to 3. So that is the maximum point, right? Plus 3 it comes out of the introitus. And BA, so this small a denotes the anterior vaginal wall and B denotes the worst descent. So now you ask her again to strain. Amma nalla mukkunga. So can you see? You can see the worst descent. This is the cervix. It is coming nicely till here. So the worst descent I am going to measure is nalla abbe mukkite irunga. From the hymen, the worst descent is up to around say 7 centimeter. Okay, 7. And how much is the cervix? From here, 10 centimeter. So we finished 2/3 of the grid. Now again AP. AP is a point. A is a set point which is 3 centimeter from the hymen. So this is the hymenal ring. So from 3 centimeter, here you have to mark this point. Okay. Why again? There anteriorly that 3 centimeter represents the urethrovesical junction or the bladder neck. Here this 3 centimeter represents the anorectal junction. So you visualize where this point is and now ask her to strain and see where it comes. Nalla mukkungamma. So she's straining nicely, but you can see that point which you had marked is inside only. That is around -3 only. It is at the same point. So AP is -3. You mark AP as -3. Now BP. Again, BP is in the posterior segment, which is the worst descent. Amma nalla mukkunga. So nalla mukkunga. So it is descending nicely. So from here, nalla mukkupa. So from here 1, 2, 3, see this marks the attachment of the uterosacral ligament. This is the point D, and the maximum straining of the posterior vaginal wall comes here. So from here 1, 2, 3, 4. 4 is BP, whereas D is this point, and again if you measure from here, D is +5. Okay. Now, you have to stage the prolapse. In normal Shaw's prolapse, we say if it is within the nicely well settled, just below the ischial spine, we say it is first degree, and if it comes at the introitus, we say second degree, and outside is third degree, and totally if it comes, we call it as a procedentia. Here it's almost the same thing. We only use centimeters. So within 1 centimeter and outer 1 centimeter is one landmark. So if you keep 1 centimeter, if the cervix or the maximum leading point is beyond that 1 centimeter, then you call it as 1, stage 1. If it is from within 1 centimeter to outside 1 centimeter, that is -1 to +1, you call it stage 2. If it is outside this +1, then you call it 3. And you should know if it is outside. Say for example, nalla mukkunga ma, nalla mukkunga, you know it is more than +1. So when will you call it as 3 and when you should call it as 4? You will call it 3 when it is the more, but it is less than TVL -2. So TVL was 10. So if it is, yeah, TVL we had measured, no? Did we measure? We measured TVL. So if it is if the cervix is TVL -2, if it is 8 centimeter, then we call it 3. How much is the cervix here? Cervix is also 10. So it is more than TVL -2. So this is a case of stage 4 pelvic organ prolapse. This patient will require, in addition to vaginal hysterectomy, a proper apical suspension in the form of sacrospinous corpus suspension. Okay? Thank you, ma.
Please unmute.
Do we
Yes.
do we have a few more minutes?
Yes, ma'am. Almost your time is allotted time is complete. So
Over.
can you? Yeah.
If there is
Yeah.
some important point that you want to make, then
Yeah,
maybe
yeah.
a
Just
minute.
one.
Yes,
second.
yeah.
Yeah, I'll just a minute. I will summarize it. So generally, simple things like an anemic patient, this is not an ongoing blood loss. So you correct anemia, don't give blood transfusion. Infections can be treated, diabetes to be controlled. Diabetes with the post-void residue alone, beware, it could be a hypotonic bladder. That is a very important thing. I was talking of raised creatinine, putting a pessary and optimizing it would do well. Generally, we don't do these ultrasounds and MRI, just for completion's sake, I brought that. Thank you.
Dr. Ritesh, Dr. Anurag, maybe you can take a few questions. Maybe directly or from the chat box. Sir.
So I think you only asked a few questions, so you can take that. So there's a madam, there's a question. Is there any specific type of prolapse with which occult SUI is associated, or it must be assessed in all patients?
In all patients of prolapse, we must assess for occult SUI, because in an occult SUI, patient will not be suffering from SUI, but after we have done the procedure, they will come and complain as though we have caused the damage. So we
Yes,
have to assess for occult SUI and give them the option, because the current EAU guidelines talk of stage repair. So give them the option saying a manifest SUI, definitely we do. But I have been doing a combined concomitant and pelvic organ prolapse for the past 24 years. I have had no complications. But the current guidelines say you tell them that even if it is an occult SUI, whether they want the surgery or not, concomitant anti-incontinence procedure. But we have to assess, that is very sure, because you have to guide them. Guide them, occult SUI, if you treat in the same sitting, the chances that they require another surgery in another sitting will be reduced. So we have to examine all patients of prolapse, both in the reduced position and in a full position, for occult SUI also.
Yes, agreed. Nice presentation, ma'am.
Thank you, ma'am.
Thank you.
Can I ask one question? One more.
Yes, sir.
So in case you want to do a simultaneous surgery, what type of procedure for the incontinence do you prefer? Is it the sling procedure, autologous sling, or maybe tape only?
See, because we are doing it from below, I normally put a mediurethral sling along with this. I don't do pubovaginal sling. I am a very great fan of an autologous sling, but in cases of prolapse, where I'm going to do from below, I'm not putting another incision. I preferably use the mediurethral sling. I have not, I see Dr. Pavan now using autologous tape as a mediurethral sling. But for pelvic organ prolapse, I always put in a mediurethral sling.
There is another question from the audience. How can we prognosticate the chances of postoperative CIC? If the patient does not have high residue earlier, after the procedure, what are the chances, and how many patients for a few days you can have a chance of CIC?
Yes.
Can you tell it beforehand?
Yes, sir. In a patient, I little rush through the slides, especially if I am seeing a patient with a preoperative increased post-void residue. For all, I always tell all my gynec friends to do a whole abdomen ultrasound with the post-void residue assessment. If there is a significant post-void residue, I counsel them telling, we are going to correct the mechanical aspect of the prolapse. But how they will behave later, we don't know. So they may require CIC, especially in those diabetic patients. If we do a urodynamic evaluation, we can assess that their PDET at Qmax is low, then they may have voiding dysfunction. Whatever it is, for the mechanical aspect, we have to do the surgery. But we counsel them, especially in diabetic patients with increased post-void residue, I will counsel them for the need of CIC. That is number one. Number two, in all patients who undergo a pelvic organ prolapse or any surgery from below, I always tell them that after you remove the catheter, please check if they are voiding well or not. You don't even have to do a post-void residue assessment. If you really ask them, are you passing urine normally in adequate quantities? If they are passing urine adequately in normal quantities, then there would be no need of a CIC. But if they are passing small quantities of urine frequently, then you need to do an ultrasound to check for post-void residue, and then either put in a continuous bladder drainage for a few more days or teach them CIC. I'm finding it difficult to teach them CIC. So I put in case there is increased post-void residue, I put in a catheter for a few more days and send, and then all that bladder neck edema comes down, their pain becomes all right. When they come for the next review, they are fine and they are all right. But the only carry home message is, after any surgery, and you remove a catheter, please always yourself, your staff, your residents, look out for any voiding dysfunction. And if
Thank you,
there is
ma'am.
any voiding dysfunction, put a catheter.
Right.
That
Thank
is
you.
what I would say.
Ma'am, there is, if we have, can we have one more question which has come?
Yes, sir. Yes, sir.
So the question is, which one is best for incontinence, pubovaginal or mid-urethral sling, without considering a second incision?
In pelvic organ prolapse, I have always been using a meduretral sling with very good results. If I don't think it is an ISD, even transoperator taping is very good. But if there is a significant leak, and I think in terms of an ISD, I go for a retropubic taping. Otherwise, meduretral sling transoperator itself is good enough. Though scientifically, retropubic taping is the best. If you take the world literature, the reports are very good. Otherwise, you have very good results with meduretral sling. Pubovaginal sling, I'm a great fan of this autologous rectus facial sling, and I do it for ISD with very good results. But when I'm combining, I put in a meduretral tape.
Thank you, ma'am. We now invite our next speaker, Dr. Uday Beniwal, who is a senior consultant at Narayana Hospital, Jaipur, and he'll be speaking on office evaluation for SUI. Dr. Uday, please. Dr. Uday, you are not audible. You are not audible. Please unmute yourself. Dr. Uday, please unmute yourself.
Yes. Sir, if you are using microphones, maybe use the desktop's microphone rather than the earphones. Or you will have to choose the earphone plug as your microphone.
Dr. Uday, you can use the computer.
Not yet audible, sir.
Uday sir, you can remove your AirPods. Yep. Remove those.
Switch them off, it will take over again.
Yes, yes. Now,
Go to the audio. Go to the audio and connect it to the computer. You're not audible
Till
right
that-
now.
till that, can we move to next speaker?
Okay, so our next
Uday
speaker
sir,
is
please try to fix it the problem.
Maybe relog in. Yes. We can take the next speaker. Yeah.
Dr. Mayank, please. You'll be
Yeah,
speaking.
am I audible?
Yeah, Dr.
Yes.
Mayank. Yes, please go ahead. You'll be speaking on urodynamic evaluation before surgery, need, scope, and impact on therapy. Dr. Mayank, you can start, please.
Yeah. Just 1 second. Is my slide visible?
Visible, sir.
Hello?
Yeah. Yes, sir.
Visible, yeah.
Visible.
So, although it's like bypassing a very important presentation, but I will be concentrating only on the urodynamic perspective, how it can help and how it will not. So, first of all, I would like to cover what are the urodynamic findings of interest as far as the incontinence and prolapse is concerned. So in the filling phase, we would like to know the compliance. And I think this is an important point when we are looking for a patient who's severely incontinent or has a small capacity, in which poor compliance is defined as less than 20 to 30 ml per centimeter of water. I assume that people are aware of the poor compliance graph, which is on the right side compared to the left side, in which the compliance is good. The diffuser pressure remains nearly zero all the time. And then DLPP of more than 40 in a patient of poor compliance is a marker. Actually, now it is more, I mean, the DLPP of more than 20 is considered high risk for, upper tract damage. So we should be careful about it. Then diffuser overactivity, whether it's phasic, terminal, or associated with cuff. On the left side, in the middle, we see terminal. On the right side, we see the cuff-associated diffuser overactivity. Should be taken into account, and they may have implication on the results of incontinence prolapse surgery. May not be deciding factors. In filling phase, we would like to see the abdominal leak point pressure, whether it is by cuff or by Valsalva, not very sure. But one thing is very sure, we should use a very sensitive method in seeing the leak. Uroflowmetry activity is the least sensitive and not a preferred way of seeing a leak. Best is to look directly into the introitus, although it's very uncomfortable for a woman. Or else, if you have a facility for video urodynamics, you can look for any contrast coming into the urethra during the Valsalva or cuff leak point. More than 90 centimeter of water of ALPP is suggestive of urethral hypomobility leak, and less than 60 is considered suggestive of ISD, although it is not proven uniformly at defining of these entities. The least important, but have some importance, is the resting urethral closure pressure. If it is less than 20 versus more than 40 are defining factors between urethral hypermobility versus in sphincteric intrinsic sphincter deficiency. Considering both factors together, if a patient has less than MUCP 20 and less than VLPP of 60, is a more important parameter in defining intrinsic sphincter deficiency. Then in voiding phase, we have parameters of high pressure, low flow voiding, in which is suggestive of bladder outward obstruction, important in a case of prolapse. It suggests presence of bladder outward obstruction suggests that the patient's voiding dysfunction is likely to improve after prolapse surgery. If you have a UPP or a video aerodynamics, you can actually see where the obstruction is happening. Like in our UPP patient, we saw the block in the approximately mid-urethra, which is the point of kinking. One may have a low pressure, low flow voiding because of either sphincteric dysfunction or as a primary underactivity, or one may have a normal flow. If a patient has a normal flow during urodynamics, so that means there is no obstruction. But in this, a PDET Qmax of less than 12 indicates a higher incidence of post-operative retention and voiding dysfunction after a suprapubic tape compared to an obturator tape. So this point should be considered. Now, some representative studies of SUI. In the filling phase, we see the leak. Actually, in the UDS, it's not possible to show. But at least in this graph on the left side, we see that the PDET Qmax is more than 12. Compared to the right side, it is very low. So the right side patient is more likely to have a voiding dysfunction after a suprapubic tape. But more likely doesn't mean 100%. It means like 5% versus 25%. But 75% still will not get a voiding dysfunction after even suprapubic tape if it is applied properly. Cystocele, we will see this obstruction. In the voiding phase, you see that initially the patient voided nicely with relatively low pressures, but as the kinking happened, the obstruction happened. So it just shows that the problem is because of the cystocele, and cystocele repair is most likely going to cause improvement in the voiding dysfunction. However, there will be artifacts. I'm just taking it away. So in urodynamic study in a woman, in our experience, we see sphincter spasm happens quite commonly during the urodynamic study. I will ask this question to other urodynamicists. How do they feel? But in my experience, if the urodynamics during the urodynamics, the patient develops sphincter spasm, like in this patient, we can see in a case of SUI, you have a very good uroflowmetry, but the urodynamics is like this. It is obviously considered of induced sphincter spasm. So in this urodynamic study, we'll not get a proper VLPPs because of sphincter spasm. The VLPP will be falsely high. The MUCP will be falsely high. The voiding phase will be falsely showing voiding dysfunction. So this urodynamic study, I think, is a fail in this situation. Similar situation in a urgency incontinence patient in which there was a clear bladder outer obstruction with the catheter in C2. And as I remove the catheter, see the flow on the right side. Similar situation in a cystocele. This is the flow, free flow, not represented by the urodynamic study, or in a uterine prolapse patient. To conclude this point, if the urodynamic study is not representing your pre-operatively done bladder diary and uroflowmetry, or it is way too much away from your clinical symptoms, that urodynamic study is not valid in my experience, and that will not contribute to your treatment. So there was a large database analysis of urodynamics from Netherlands, in which they found that up to 65% of urodynamic studies are discordant in a carefully done urodynamics in 2,000 patients of stress incontinent. It was more common in uncomplicated, in the complicated SUI patients rather than uncomplicated SUI patients. I'll come to that later. What were the discordants? Like 765 mixed incontinence converted to SUI urodynamically, 330 SUI converted to mixed incontinence, 181 SUI converted to urgency or CADO, no SUI, and out of only 32 were suspected preoperatively as having voiding dysfunction, whereas in 394 urodynamically diagnosed with voiding dysfunction. Now, the treatment was modified based on urodynamic in about 19% of their patients, which was much more common in complicated group versus uncomplicated group. And the most common change was converting TOT to TVT or TVT to TOT, depending on presence or absence of voiding dysfunction, or a low pressure voiding, or diagnosis of IST. Surgery was cancelled in 151 patients based on urodynamics. However, we still don't know what happened to these patients later. So for uncomplicated SUI, which is slightly variably defined, but USI guidelines clearly define uncomplicated SUI, that a woman who's younger than 65, who has a stress-induced leakage of urine, there is no urgency-related leak, which is varied from a value trial in which they had, say, included even stress predominant mixed incontinence treatment also. There should be no significant prolapse. There should be no prior pelvic surgery or radiation therapy. On examination, there should be demonstrable SUI. Urethral hypermobility should be present, and cystocele should not be stage 2 or more. And the uroflow should be normal with a low PVR. Although the value trial had shown PVR as less than 150, but there is no clear definition for low PVR. So in these patients, in these groups, randomized control trials have shown that up to 30 to 40% of UDS will be discordant with the findings, and the results of surgery will be equivalent, which is about 75% cure rate in either of the groups. So UDS definitely is not essential before surgery in uncomplicated SUI, unless you want to choose between a obturator tape and a suprapubic tape. Now, preoperative urodynamics in mixed urinary incontinence, if we can diagnose presence of diffuser overactivity, will reduce the cure rate of total incontinence. So in a SUI only group, the cure was about 82% in this particular study. Whereas if the detrusor activity was also found, the cure was only 55 because the other group, patients continue to have overactivity incontinence, and this had predominantly a prognostication, not a decisive factor. One can still go for tape and say that the urgency will be treated separately on its own grounds. Then occult SUI has been discussed. I would like to skip this. There is no doubt that if we can diagnose occult SUI prior to surgery, a concomitant procedure will reduce postoperative incontinence. However, the complication rates are much higher compared to only a prolapse surgery. So this should be extensively discussed with the patient. Voiding dysfunction after prolapse surgery. So if we can diagnose a voiding bladder outer obstruction in a woman before prolapse surgery, and we can prove that it is not because of the bladder neck, which is most likely it is not. So then it is a very good predictor of improvement in voiding after surgery. We can say with a lot of confidence. But if the patient has severe underactivity in this urodynamics, so we can say that the likelihood of improvement in this underactivity is very low, not 0%, but very low, because in a woman, even underactivity, if the patient has a very good pelvic floor relaxation, can have an adequate improvement in voiding. So in this study, they found that post-op after prolapse surgery, most of the patients who had a high PVR improved, but having known presence of underactivity already can help in prognosticate the patient. So urodynamic predictors of persistent voiding dysfunction after surgery have been defined as a detrusor underactivity for persistent elevated PVR, a detrusor overactivity for persistent postoperative OAB, and an occult SUI for postoperative SUI. However, the role is still not clear. It is not possible to reach a universal consensus because the pro-urodynamic person will say that you have a better prognostication, but an anti-urodynamic say that if you can counsel the patient properly, you can save the urodynamics for a post-operative persistent problem, which is not managed by conservative means. So there are no randomized study beyond uncomplicated SUI patients. So to conclude, occult SUI and voiding dysfunctions are commonly associated with prolapse. There is no need of urodynamics before surgery for uncomplicated SUI. We need to individualize urodynamics before SUI and POP in other cases, knowing what are we going to achieve by urodynamic findings, and that urodynamics has to represent the clinical picture, the free uroflowmetry and the bladder diary. Urodynamics ultimately will be more of a counseling tool rather than decisive one. Although in the complicated SUI patients, they had shown that in about 15 to 20% patients, not 50, sorry, 8% patients, the surgery was cancelled. But for the other 92%, maybe it was not a very important tool apart from counseling. Artifacts during urodynamics must be considered. I've already covered. So thank you very much for time. I'll be happy to answer some questions. I hope I'm still audible.
Yes, sir, you are audible.
Yeah.
Can you stop your screen sharing?
Yeah.
So,
yes.
Dr. Mayank, since you said that it is just about in 10% cases where the clinical findings actually corroborate with the urodynamic findings, and rest may represent an artifact or maybe a true urodynamic finding. So, your view, prognosticating based on the urodynamics, over prognostication may also be fallacious in a sense that the urodynamic findings themselves are fallacious.
Correct.
So how do you go about that clinically?
Yeah. So practically speaking, in any complicated case, I always go for a urodynamics for prognostication. But at the same time, I asked if there is a discordance with my fruit, which is not very uncommon. I've already shown that the sphincter spasm really ruins everything in urodynamic study. So what I do is, fortunately, I would say we don't have a video urodynamics. So what I do, I send the patient for a MCU and have an anatomical correlate, and then try to cognitively correlate the findings with the free uroflowmetry findings, and then give the patient a correct picture of the outcome. So I must accept that urodynamics hasn't helped too much in carefully selected group. Like a patient who has a post radiation, I'm suspecting a poor compliance. So that is obviously I would like to do urodynamics to find the patient has a poor compliance. But in other group, urodynamics has helped me. I mean, made me more confident in telling the patient something, but not very commonly it has changed their decision of going for surgery. And haven't I don't recall where I have gone ahead with the surgery without I mean in as against with the urodynamic finding, but I have repented doing that surgery.
Okay.
After 2006, there was one incident I fairly remember. In 2006, we had done a urodynamic conference, and the patient had a mixed urinary incontinence. She had a significant overactivity. It was a tape surgery was shown. After the surgery, stress incontinence had improved markedly, but her overactivity had worsened markedly. She had become really, she had become miserable after the surgery, and we had to take the tape down. Apart from that, I don't think it has helped too much, apart from prognostication and making me more confident.
Dr. Meg, Dr.
Sir.
Meg, in case of mixed incontinence, how many
Sir.
patients you think by just treating the urge part will be, all right? They'll not mind with the incontinence being mixed in the beginning, because many females they believe that it is common to have a mild stress incontinence.
Sir.
And they are more worried because of the urgent incontinence part.
Sir.
So if you treat them medically, will they be all right without surgery?
Of course, sir. Of course, I have patients who have mixed incontinence, and I've taught them pelvic floor exercises very well, and their SUI has reduced, overactivity has continued, and they're doing well on Botox only. But I always urge that you continue pelvic floor exercises, because the SUI part has been taken care of, and there for them that much of residual SUI is socially acceptable. So you're very right that we don't have to barge. I mean, like suddenly go towards sling placement for a mixed incontinent patient. We have to give a very good conservative, treatment, and
Actually, one
treat
should
the
learn
most
her
predominant
practice.
incontinence, not necessarily stress. Maybe like in these patients, I'm telling that SUI is manageable, but urgency has needed Botox.
Yes, sir. Can I
Just now,
just
Dr.
pass a comment?
Shrikala has pinged that predominant symptom to be taken care of, very rightly said, not tape for everyone.
So we can move ahead and take the question after the next presentation, maybe.
Yes, sir.
Yeah. Thank you, sir. Please continue with us. We may need your judgments for our clinical case discussions also.
Sure,
Dr.
sir.
Maya,
Thank you.
Stay with us. Yeah.
Uday sir, please share your screen. That's fine, sir.
We can see your
Make
slides,
it-
sir. Yeah. Make it full screen and go ahead.
You are not audible.
Dr. Uday?
you need to change audio in your setting. Your presentation is visible, though it's not full screen. That's okay, but you are not audible.
Okay, we can have one or two questions that were remaining while he's setting it up.
Chairpersons, please ask the questions.
Dr. Sudhir, you wanted to ask something?
I was just actually putting passing a comment regarding the previous discussion, as Dr. Mayank said, like there was one patient of mine also whom I have recently seen who had mixed urinary incontinence. However, when we examined her, actually her symptoms were predominantly urge related rather than stress related. She has stress urinary incontinence. So my point to take that the predominant symptoms should be treated in such type of patients. Suppose if you have on examination, there is no high grade prolapse associated with that or any pelvic descent, and you have predominant stress urge incontinence symptoms, and this lady, we have focused more on treating her urge symptoms in terms of medications or active medication, bladder medications, but she didn't respond. And subsequently, when we did a urodynamic study in her, she was having severe bladder overactivity. Even the early contraction, involuntary contraction started occurring at as low as 50 ml of bladder capacity. So since she was not responding to the drug therapy, she was taken up for Botox, intravesicular Botox, and subsequently after that, she had significant improvement in her symptoms. So just reassuring the point that when you have mixed incontinence, try to consider the predominant symptom to be treated and then accordingly proceed. That's a comment which I want to pass.
Okay.
Rishi, can I just come in on this point if you have time?
Sure, sir.
Yeah, so this is again just for the sort of knowledge of postgraduates who are here. Evaluation of mixed urinary incontinence is very critical, as all the people have said here. The important thing here is to know that a lot of ladies who have stress incontinence will be going frequently to void in order to prevent the next leakage of SUI. So they may falsely present as urge incontinence, whereas actually you go in detail in questioning and they are more worried that when their bladder fills, the SUI will happen. So that they say that, yes, I have to go urgently. But it is the fear of leaking because of which they go urgently. It is not actually classically urge incontinence. So just a point that in evaluating a patient with mixed incontinence, this factor should be taken into consideration. Thank you.
Dr. Gautam, am I audible now?
Yes, sir. Yes, sir. You are very well audible.
Okay, sorry for interruption.
Yes, sir. Please upload your slides. Share. Yes. Thank you.
Is it visible?
Yes,
sir.
yes. Make it full screen.
Please go ahead, sir. Full screen.
From beginning, you click the from beginning. Left corner, yes.
Anyhow, we can go see the slides if
Yes,
it
yes,
is
sir.
Yes, sir. Yes, yes.
Yes. Thank
Done.
you.
Yeah, now goes.
Good morning, chairpersons and all the members. I will discuss about office workup of uncomplicated SUI. For diagnosis of SUI, we need a combination of history and physical examination. Video interruption.
Yes, sir. We can see, sir. Please go ahead.
Okay, leave. When women are evaluated for SUI, minimum evaluation should include few points like history, physical examination, urinary analysis and post-void residual urine, demonstration of SUI and assessment of urethral mobility. In history, we should make out what are the predominant symptoms. Is it only stress incontinence or there is associated urgency incontinence? we should ask for pelvic organ prolapse or anal incontinence or voiding history, like there is some storage symptoms or voiding symptoms. We should also ask for medical history which may contribute or worsen SUI, like there is some neurological component, diabetes, or menopausal history we should take for hormonal changes. In physical examination, in pelvic examination, we should check for any urethral mass or pelvic mass, or we should check for pelvic organ prolapse. Next is urinary stress test. In all the recent guidelines, it is mandatory to observe for urinary stress test before going any surgical treatment for SUI. In urinary stress test done in supine lithotomy position, and leakage should be simultaneous with increased intra-abdominal pressure activity like cuffing or Valsalva maneuver. If leakage occurs slightly later, it may be stress-induced detrusor overactivity, so it should be simultaneous. If leakage of urine is not observed during supine position, then one should examine in standing position, because sometimes in supine position leakage is not observed. Another test is assessing urethral mobility. Urethral mobility is also tested in supine position with Q-tip test, but it is a slightly painful test, and it is considered positive when there is more than 30-degree mobility from horizontal plane. And if there is urethral mobility, it indicates uncomplicated SUI. But there is no gold standard regarding this test. Another point is we should check for post-void residual urine, because if there is more than 200 ml of residual urine, it indicates that patient may have a problem in post-operative period. If we do some surgery, then patient may have voiding problems. And another test is urine examination. We should rule out urinary infection by urine examination, because it may worsen stress urinary incontinence. So we should treat urine infection before going for any intervention. Another test which is urodynamic, I am not discussing to cut short the presentation because it is already discussed with Dr. Mayank. Urodynamic study is indicated in complicated SUI, like when there is mixed urinary incontinence or significant PVR, or when there is urinary incontinence without urethral hypermobility, or there is history of some previous surgery. Then UDS is indicated, which is already discussed by Dr. Mayank. Thank you.
Thank you, sir. So, thank you all speakers and chairperson for this presentations. Now let's move to the second set of the presentation, which include the clinical management of the prolapse and cystocele. For this, the chairpersons are Dr. Govind Sharma from Jaipur, Dr. Mahendra Singh from AIIMS Jodhpur, Dr. Agarwal from Jaipur region again, Dr. Subhas Yadav, and Dr. Anurag Yadav, sir, again. So I call upon all chairpersons to call their next speaker.
Good morning, all. Myself, Dr. Govind Sharma. For the next speaker, I want to call Dr. Sudhir Kumar Devana. Thank you.
Am I audible?
Yes, sir.
Good morning, all. Respected chairpersons. At the outset, I want to thank the NZUSI Council, Dr. Rishi Nair and Dr. Gautam for giving me an opportunity to participate in this webinar. So the topic that was given to me is on conservative management of cystocele and prolapse. Of course, conservative management is often discussed as one of the first line treatment of these patients, and it's very easy to explain to a patient, but it's very difficult to follow the conservative management in such type of patients, where both the patient and the physician commitment is very important in the conservative management of prolapse. So first, what includes a conservative management, particularly related to pelvic organ prolapse? So these are interventions other than pharmacological or surgical treatments, which include lifestyle modification, physical therapies, and the pessary treatment. So the first step of any patient of prolapse where you want to treat with conservative management or any surgical therapy is very important to educate them as to what is the pelvic anatomy and also the types of prolapse which the patients develop. And by collaborating the examination findings of that given patient and explaining them that these are the structures which have prolapsed to the patient, will give a fair idea of the patient, that they will understand what they are suffering from. And also it's very important to tell them what the pelvic floor muscle function is. If you go about this is just a slide which I'm showing basically on the educating the patients regarding pelvic organ prolapse. The American College of Obstetrics and Gynecologists have provided in their website some interactive videos of how the prolapse occurs, and the photographs which I'm showing here, these are actually taken from that only. So if anybody who is interested to, these videos help actually in educating the patients as well. So you can go through these videos, which will clearly explain how a prolapse occurs. Now, coming to the main topic, the conservative management, the first and foremost important thing is the lifestyle change. Of course, this is important for many of the medical problems which people suffer. So these also help in improving the symptoms of prolapse. And it is a known association that occupation related to heavy weight lifting or and the increased body weight, and also the associated bowel function, which are associated with increased incidence of prolapse. So obviously, the publication which I am showing here is actually shown an article which has shown that the pelvic organ prolapse symptoms actually correlate and even associate with associated bowel or bladder dysfunction. So patients who increase their intra-abdominal pressure due to various regions can lead to increased incidence of prolapse. So whenever we are talking about the lifestyle advice, obviously you have to correct these problems which the patient have been are suffering. Like for example, treating constipation, or when they have an associated defecatory dysfunction, that also should be looked into and that also should be corrected. Increasing the fiber diet, adequate hydration, and with good bowel habits help in not only in decreasing the incidence of prolapse and also improving the urinary symptoms as well. Even weight reduction, I think everybody know about this, that the obesity is associated with increased incidence of prolapse and also urinary symptoms as well. The stress urinary incontinence is also associated with increased weight. So weight reduction should also be an important part of lifestyle advice. Other than this, you can add upon like stopping smoking or any irritants to bladder which are associated with increased incontinence. So if you go into the evidence that is available, the evidence related to lifestyle changes is that it has a more of a preventive role rather than a treatment role for prolapse. So the evidence related to treating a prolapse is lacking, but of course, when you follow a good lifestyle, obviously the chance of you developing a prolapse would be lesser. Now, the most and important and the difficult to do is the pelvic floor muscle training, which is very important part of a conservative management of any prolapse patient. So how to do, first step is to go for the assessment of the pelvic floor muscle function. So there are a lot of ways you can assess the pelvic floor muscle function, but the most important thing which we routinely do in our clinical practice is the palpation. So by palpation, how to proceed? First, putting an index finger in the vagina, and of course, in the vagina, by placing the finger in the vagina, you can feel the pelvic muscles. More so, the most important thing related to the prolapse and the stress incontinence is the levator ani. And then ask the patient to voluntarily contract these muscles. And the most important problem with this is the patient is unable to understand which muscle they want to contract. Many a times, they contract the rectal muscles, they contract the gluteal muscles, or they contract the inner thigh muscles in a way to show the contraction in the vagina. So it is our duty to clearly explain them how to identify these muscles, that when you contract it, obviously the vaginal introit moves inside, and even you can see the wink of the anal muscle when the patient is correctly contracting the muscle. So that's what you have to teach them. And for assessing the pelvic floor muscles, there are different validated scores are available. I just want to emphasize on this Laycock perfect assessment scheme, which is an important thing, because many clinicians can actually follow this to teach their patients how to train their pelvic floor muscles. So this perfect score is a mnemonic where you can see the P stands for power, E for endurance, R for repetitions, and F for fast. The first 4 letters are the main things which we are going to teach the patient. And then every contraction has to be timed. Now, the first important thing what you have to do is the maximum voluntary contraction of the vaginal muscle you have to look into. And the muscle power can be graded using the Oxford grading like this, like it ranges from 0 to 5. Like if you go one by one, the first one is power. So by contraction of the bone, assess the power. The second thing is the endurance. See how much time the patient is able to maintain that contraction before its strength decreases by 35% or more. That means you have to see whether the patient is holding or gripping your finger for how long. That is endurance. The next thing is repeating the same contraction again and again till how long the patient is able to do that contraction. Because after a period of repeated contraction, obviously the muscle will become overloaded and the patient will fail to contract it. So that one you have to record. And the last one is the fast. How many times? Ask the patient to do a quick contractions of the pelvic muscles to see how many times she is able to contract that. For example, to show it, like in this patient one, I am showing here PERF, the score given here is 3547. This means that the patient has a power of 3 and endurance is 5, means that means she is able to maintain that contraction for only 5 seconds and she is able to repeat the contraction for only 4 times, whereas the fast contraction she is able to do 7 times. So in this given patient, today you have the score like this. Now you have to tell the patient that you have to improve the power strength by doing these repeated sustained contractions every day, and also the endurance duration, which is 5 seconds, has to be increased up to 10 seconds. So teaching the patient and giving a baseline score and then reassessing it again and again will help. This is another example similarly with a low power, which I am showing here how they have mentioned it. Now, the next step is teaching them a sustained contraction. Sometimes a rapid quick flick contractions also are needed for preventing urge incontinence. So the NAC maneuver is a maneuver similar to that, where you contract the pelvic floor muscles to prevent leakage of urine. And it's not just teaching once. You have to tell them to consistently do this exercise daily at home. Weekly a regimen should be done, like every week or once in 2 weeks, the patient has to come back again and you have to check again whether she's doing the proper contraction or not. So multiple one-to-one appointments, and then the independent home-based exercise also they should do. Of course, if you have a pelvic floor physiotherapist, it is more useful to the patient. And what improvement can we expect with this pelvic floor muscle training? And over a period of time, the patient's symptoms can improve. The stage, whether pelvic floor muscle training can reverse the stage, that you have to see. If you go to the evidence, definitely the treatment, there is level 1 evidence to say that pelvic floor muscle training definitely helps in improving the symptoms. Not only the symptoms, but also the stage can be reversed. Like a patient who has a stage 2 prolapse, it can be decreased to 1, which it looks a little bit odd that whether the anatomy will get corrected or not. But in the studies, published data, like in this paper, which was published in Lancet, it is POPI trial, where they have clearly shown that at 12 months, there is significant improvement in the pelvic organ prolapse symptom scores. And not only that, if you see the stage migration, you see the around 27% of the patient, the stage has improved. And also the further need for treatment in future have also decreased. Now, if you go through the meta-analysis, definitely in randomized trials, it has shown that most of the trials have shown that there is definitely benefit of pelvic floor muscle training in terms of improving the prolapse symptoms and also the urinary and also the bowel related symptoms as well. But most important is supervised pelvic floor muscle training. That is a very important thing. And stage migration also has been shown in this trial as well. Even you can combine the lifestyle advice with pelvic floor muscle training, as shown in multiple random trials, that it is going to benefit the patient. Now, the next and the last important part of conservative management is the pessary treatment. I think the previous speakers have already touched upon this. The American Urogynecology Society is following a Choosing Wisely campaign, where in one of the part they have clearly mentioned that don't exclude pessary treatment as a treatment option for pelvic organ prolapse. All patients, irrespective of the severity of the prolapse, the pessary trial definitely gives a lot of idea as to whether the patient, how this is going to improve or not. And the Urogynecology Society best practice statement also recommends that women who are needing a treatment would definitely, the pessary trial should be considered. And it can be short term or long term. And sometimes patients who have high grade prolapse, when they're planned for a major definitive surgery, before surgery, the pessary trial can be given. Even if you have an ulcer, decubitus ulcer, by putting a pessary, the ulcer, when once it is healed, then the patient can be taken up for surgery. Sometimes when the clinical symptoms are not correlating with the severity of the prolapse, even it has a diagnostic value in terms of by putting a ring pessary, the occult stress urinary incontinence can come back again, can be shown, or even the patient symptoms can be correlated whether they are going to improve with pessary or not. This is a little bit theoretical slide where a lot of pessaries are available, the support pessary and space occupying pessary. But of course, the most commonly used pessary is the ring pessary. These are few of the pessaries, according to the size of the vagina, you can put these pessaries. And one question was asked in one of the previous discussion, that how to assess which size of pessary should be placed. And when I discuss this point, with my gynecology colleagues, specifically, they say that they routinely assess the distance between the sacral promontory and the pubic symphysis, and that gives a fair idea as to what size of pessary has to be placed. And the ideal patients, yes, those who have high risk patients because of comorbidities, or frail patients, and patients who don't want surgery, yes, these are the patients who are ideal for vaginal pessary. But when you have a large genital hiatus, or a large rectocele, or a short vaginal span, these patients are not ideal.
Please wind up.
Yeah. Coming to the final slides, like pessary treatments, the patient also, if the patient is educated, even if they are able to self-manage, it is better. And the side effects of pessary treatment are the vaginal discharge and the vaginal bleeding are the most common side effects. And if you go to the evidence, there is a level 2 evidence to say that pessary treatments in all the trials have clearly shown that using a pessary will definitely is going to help the symptoms of prolapse, and also the improvement in the urinary symptoms as well. But only thing is the dropout rate and satisfaction when on the long run is lesser, because if you see the various published literature, the dropout rates are as low as like 40% to as high as 80% is there, and even the satisfaction is also from 50 to 80%. So for the permanent solution would be surgery. Definitely surgery offers a far better improvement in case of high grade prolapse. But if you consider low stage prolapse, definitely pessary is a good treatment option. So I summarize my talk saying that definitely conservative treatment of prolapse is a non-invasive and a low-cost first-line treatment option for all patients of prolapse. And the patient symptoms and what the patient expectations and goals should be considered whenever you are giving this option. And the most important thing is the need for continuous patient and physician participation, because for you to get the outcome of benefit of pelvic floor muscle training, the patient also should be motivated, and at the same time the physician also should be actively participated to give a better outcome in these patients. Thank you.
Thank you, Dr. Sudhir. I have a question for you. If a patient is being well satisfactorily managed on pessary, can she be left on this for permanently?
Yeah, sir, the pessaries, which are most of the times are available, are made up of silicone material, and they are not very much irritating to the patient, provided the patient follows it. Like like I said, the most important thing for a pessary is at every 3 months at least you have to change it, and they have to be aware of the warning signs of a pessary side effects, like in the sense of, if they have vaginal bleeding, or sometimes they have unusually increasing the pain in the lower part of the abdomen, they have to be in close contact with the physician to come back and change the pessary. So if you are properly changing it at a regular intervals of time, and definitely on the long run also the patients do have the benefit of pessary. But in case of high grade prolapses, like you have grade 4 or grade 3, the surgery would be in the long run would be better.
Okay, if the pessary is in place, will they do pelvic floor exercises or not?
Yes. Combination, yes. Always the benefit of combination of pelvic floor muscle training with pessary offers higher advantage. I was clipped one of the slides where the combination of therapies. There was a Cochrane database analysis of all the trials involving pessary. They have clearly shown that the maximal benefit would be there when you combine pelvic floor muscle training with pessary rather than alone. So definitely it should be combined.
Any
I
other
have a couple of
questions?
points to make, sir. Excellent
Yes.
presentation, Dr. Parna Hegde here. For assessment of pelvic muscle strength, nowadays we use modified Oxford score, sir. You know, two
Yes,
fingers in the plan, and you can grade it from 0 to 5 bilaterally. That's one important point. Second
That I
point of
have
pelvic
kept in
muscle.
the presentation, ma'am. In the power assessment of power, I have projected that slide also. The modified Oxford score for assessment of the pressure, actually.
Yeah, that is what is universally used nowadays. But second point I want to make, sir, is about biofeedback therapy, sir. I mean, when you do pelvic floor muscle training, 50% of women often can't identify the pelvic floor muscles, and 27% often do reverse Kegel. You know, they push when you ask them to squeeze. So, like biofeedback therapy, where you can actually give them a visual or auditory cue about, you know, how they are squeezing the pelvic floor muscle, or they are actually recruiting the right muscles, followed by electrical stimulation over, 10 to 15 weeks is actually a very powerful way of, strengthening their muscles.
Yes, ma'am. Fully agree.
So is there any minimum time before considering for the surgery before taking up the patient for surgery, especially in high grade prolapse cases?
Sir, I mean, if you see the published literature, at least 3 months to 6 months of the duration of conservative management is recommended, because for you to see the change of symptomatology, all trials consider at least minimum, I would say, from 3 months to 6 months to have a change in your symptoms.
That would be with the therapeutic intent, using the PFMT in about 30 to 50% cases would respond to it.
Yeah.
Primarily the patients who have LUTS and low grade prolapse.
Low
But in
grade.
patients who have high grade prolapse, the intent of using PFMT would primarily be in terms of supportive treatment for the post-operative treatment. So in those patients, what should be the approach to conservative treatment? Should it be tried for a longer duration, or just tell the patient and go ahead with surgery?
I mean, initially, if you want to have the better outcome, even with surgery also, pelvic floor muscle training should always be part of any prolapse. You know, it's irrespective of whatever the grade may be. It will definitely have some amount of improvement, additional advantage, added effect of whatever the treatment we are offering. So I would suggest, yes, definitely you have to offer it for each and every patient, even in the post-operative period also. Because some part of muscle tone, when they regain, they have less chance of urinary symptoms compared to a single treatment.
So one point I want to make is this, that no prolapse surgery takes care of levator muscle damage. So basically, there's enough evidence that says that more the levator muscle damage, more the chance of recurrence of prolapse after surgery. And also when you repair the prolapse, you do repairs, you take improve ligamentous support during prolapse surgery. Problem is that the repaired tissue will still rest on the levator muscle, which is weak. So when you do pelvic floor muscle strengthening, the repaired tissues are resting on more strong muscles, right? So support is better, and recurrence hopefully is lesser, but there's not much evidence backing it. But yes, you should do PFMT irrespective.
Thank you. So you can
Chairpersons, please call next speaker.
नहीं अभी तो 1 बजे तक चल रहा है.
Chairpersons, please call next speaker.
Yeah, the next presentation is by Dr. Aparna Hegde from Mumbai. The presentation is regarding surgical management by vaginal repair.
Yeah, so I'm going to keep it short and spiffy, 15 minutes I have. One thing I really want to emphasize is on the apical attachment of any cystocele repair you do, because 30% of cystocele happens because of apical defect, right? So basically what happens, if you see in this graphical representation, when the apex descends, you have cystocele, right? And that doesn't get taken care of in many cystocele repairs, right? So if you look at this, previously they would do ProLift surgery, right? And ProLift was a mesh that you would put, anteriorly below the vaginal mucosa. And if you look at this, you can see the mesh curled up at the bottom, right? There is recurrence of prolapse has happened. This is transvaginal ultrasound I'm showing you. And you can clearly see that recurrence is associated with curling up of the mesh, inferiorly, because ProLift did not have attachment of the mesh to the apex. So this is called gap failure. So if you do not attach the, pubocervical fascia that is plicated to the apex, whatever is the apex, the cervix or uterosacral ligament or cardinal ligaments, you will have gap failure between the repair and the apex. So I'm going to take you through different scenarios, right, of anterior repair. When you do anterior repair, one thing to always remember is symmetry of repair. Always have apical support, and the apical support should be with a permanent suture to prevent anterior enterocele, right? So let us look through various scenarios. So first thing is, if you're doing cystocele repair with cervix in situ, right? So obviously you will infiltrate first, and after infiltration, so this is like a semi-live video I'm showing you. Once you've infiltrated, you're going to take midline incision. So I've held up the vestigial folds lateral to the extraurethral meatus with Alice forceps. And then we symmetrically apply Alice forceps. Be careful that you're actually going the right plane. If you infiltrated, you're going to get the right plane more easily. But you have to go in the plane between the vaginal mucosa and the pubocervical fascia. And never have pubocervical fascia, on the vaginal mucosa. The dissection has to be between the mucosa and the pubocervical fascia. Right? And you will go until 1 centimeter from the cervix. Very important. Right? So now you incised apically till the 1 centimeter from the cervix. And then look at the symmetry that of how the Alice fossa holding apart the vaginal mucosa, right? And the assistant will then slowly retract each Alice forceps to give you traction, and then you will dissect off the vaginal mucosa from the pubocervical fascia from the vaginal mucosa. And getting the right plane is so important. You see how the planes are being created here. Right? So you're going to keep moving on the Alices as you go distally. So when you dissect off the pubocervical fascia from the vaginal mucosa, you will do it till the pubic bone, right? And when you do till the pubic bone, you will be able to actually then get the pubocervical fascia easily. You'll see the pubocervical fascia afterwards when I finish the dissection on the other side, right? This is like a semi-live video, so you can be able to do it this way. Right, so now you see clearly, slowly, the pubocervical fascia will come into view. The pubocervical fascia has got defect in the midline, and laterally it's attached to the pubic bone. Right, so sharp and blunt dissection. And then once it's done bilaterally, so you can see you can clearly see the pubocervical fascia, and then now you're going to detach the pubocervical fascia apically till the cervix. So my index finger is on the cervix, and apically I'm dissecting off the pubocervical fascia from the cervix. So this is how you're going to get it, and you can clearly see the bladder pouching out from the damaged in between the detached pubocervical fascia in the midline. Right, there's a damage in between, and then you go on to the pubic bone. Right now, and here distally, apically to the cervix. You can see the video clearly, right? There's no lag, right?
No, no,
Yes, ma'am.
very clear.
Yes.
Yeah. So basically, if you see apically till the cervix, you can actually feel the cervix. Very important. Okay. And now you start plicating. When you plicate, look at how I plicated. It is with number 1 vicryl, and you go from near the pubic bone, take the pubocervical fascia, right, and either side, right, and look at how you can clearly see how tough the support is. See, and when each side you're going to get the pubocervical fascia properly, right? See, and once you take the first suture, the pubocervical fascia presents itself to you clearly. And when you're doing the repair, you can clearly see how beautifully the bladder is getting pushed inside by the tough pubocervical fascia. And when you feel it, it'll feel much tougher than the bladder. I mean, the bladder. Right? Now, the very important step is this. You plicate it till the apical portion, and then the important point is the last stitch. The last stitch should go through the apex. So the last stitch will be a permanent suture. You use silk. So I'm showing you. I've gone through pubocervical fascia. Now I'm going through the cervix in the midline. See this, right? And then pubocervical fascia. So basically, last stitch is permanent suture, silk, pubocervical fascia, cervix, pubocervical fascia. Very, very important. Then what happens is there's no gap between the plicated pubocervical fascia and the apex. This is a patient in whom you're going to keep the cervix in situ, right? You're going to push the cervix inside. See this. Nicely push it inside and then tie the knot. So again, I'm going to repeat. You're going to plicate, 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 and then last stitch will be a permanent suture that goes through the pubocervical fascia, cervix, pubocervical fascia, push the cervix inside, and then tie the knot. And then obviously you are going to fashion, the vaginal mucosa, cut off the excess vertically, and then you're going to close using number 20 vicryl continuous sutures. Right? Now that was when you're doing cystocele in patient in whom you want to keep the cervix. There's no hysterectomy concomitant, right? Now, if you're going to do cystocele repair with a retropubic or transuppurator sling, earlier when I was training, oftentimes you do it in this manner, right? You've done the repair, cystocele repair, and then you put in the sling. This is what we would do. But I did a lot of ultrasound work, and we could clearly see that if you do both cystocele repair and the sling through a single incision, like you can see here, there is displacement of the sling proximally, very clearly. This paper of mine, which is published, which shows clearly that if you do transuppurator sling or retropubic sling along with concomitant anti-repair through single incision, there is more likely of failure because the sling tends to push, shift proximally. So always do through separate incisions. So what do you do? Through naive tissue, you'll first do sling, but not tension it. Okay, you put in the sling, but you not tension. And then you're going to do cystocele repair through second incision. And you should ideally have around 1 centimeter distance between the sling incision and the anti-repair incision. Always. Do not suspend the sling, do not tension the sling till you've done the anti-repair or the vaginal hysterectomy or any apical suspension you're going to do. After doing apical suspension, like even when you're doing the anti-repair, I showed you that you are actually going to push the cervix inside and then tighten the last knot, right? So do that. Suspend the apex and then only tension the sling. Okay. So again, put the sling, do not tension, take a separate incision, do the anti-repair or whatever other repairs you need to do. Suspend the apex. After suspending the apex, you're going to tension the sling. Very important. Why? Because if you tension the sling before doing the apical suspension, there can be distortion of the anatomy. Now look at this here clearly. The distance I'm going to show, that was the incision of the sling. Okay. And then there is a 1 centimeter incision between the anti-repair and the around 1 centimeter incision distance, between the anti-repair incision and the sling incision. Now, if you're going to do anti-repair during hysterectomy, now if your gynec colleague is doing hysterectomy, they would have done these uterosacral cardinal ligaments, right? In my practice, I always tend to do uterosacral ligament and cardinal ligament separately, right? Then the cardinal ligament will be my apical support. So when I am doing anti-repair after hysterectomy, I am going to keep the cardinal ligament stump long. The last stitch will be pubocervical fascia, cardinal ligament, pubocervical fascia, and then push the apex inside and then tie the knot. So look at this. I've gone through the pubocervical. This is the last stitch. I've done the plication till the last stitch. Then it's going through pubocervical fascia using permanent suture. Then the cardinal ligament. Look at the stump being held long. You go through the cardinal ligament and the cardinal ligament on the other side. I hope it's clear. And then pubocervical fascia. So I'm showing you different scenarios of suspension apically, right? And then pubocervical fascia. It's always ideal to do uterosacral cardinal ligament separately and not together because you get better support. Just using in one clamp everything, you don't get all the ligaments, right? See now how nicely it is apically pushed inside. Lastly, when you're doing anti-repair for recurrent prolapse following hysterectomy. So this is a walled prolapse, right? So in that, at the walled, you would be having plicated uterosacral ligaments from the previous surgery. So again, the same thing. You're going to mark out the walled. See this silk suture has been put at the walled. And then you're going to incise your anti-repair. And the midline should be till 1 centimeter from the apex. And the last stitch should be going through the walled, right? No gap between the walled, the apical ligaments and the pubocervical fascia. So again, apical suture. And then the pubocervical fascia. It's a very important take-home message because the regular anti-repair done previously did not have this apical suspension. Right? Okay. Now, the most important take-home message is this. Providing apical support is very essential. It will correct more than half of the anterior wall prolapse. Higher prolapse recurrence is seen in those who do not undergo apical repair. If you see the 2013 study of Albert et al., it is seen clearly that the 10-year reoperation rate is lower when you do combined anterior and apical repair. So if you cannot do apical repair in patients who got stage 2 anterior wall prolapse and beyond, it's something that you need to be careful about, right? You need to have somebody who can do apical suspension, right? So what I mean apical suspension, what does it mean? Not just that your pubocervical fascia plicated should be attached to the apex. You also have to do apical suspension of the walled, right? So if you have stage 2 walled prolapse or uterine prolapse or beyond, always also provide apical suspension along with cystocele repair, right? So how do you do that? So now, for example, in this patient I showed you previously, right? This is a patient who's got walled prolapse also. So you have a look at the cervix, right? Stage 2. So you have to push the apex inside, right? You have to do some apical repair along with the cystocele repair. If you do not do the apical repair along with cystocele repair, what can happen? You can have increased recurrence rates. So remember that. So every time you do POP-Q, always state the apical extent of apical prolapse also. And if this apical prolapse stage is 2 or higher, also do apical suspension, right? So then it comes to, and we're going to discuss various ways of doing apical suspension in a case-based discussion, right? Next comes paravaginal defect. Now, paravaginal defect repair was developed out of the belief that level 2 vaginal prolapse stemmed from detachment of vagina from the arcus tendinous fascia pelvis, right? So you have a whole thing of lateral, defect where you have the pubocervical fascia detached from the ATFP. Now, Bursch is a kind of paravaginal repair, right? And so it was used to address urine leakage along with anticorporaphy. But the problem is this, right? A randomized trial showed that there's a huge paradox here. Bursch is a kind of paravaginal repair, but it's not effective in treating urinary incontinence, but not prolapse. And anticorporaphy is good to treat prolapse, the cystocele, but not, incontinence. So you really need to attach paravaginal sutures, right? That is the whole issue that's come up. So now paravaginal defect repair has fallen into some kind of disrepute, not necessarily done all the time because there are not many trials for the same. And also it has been clearly seen that if you do apical procedure alone, for example, sacrocolpoplexy, then you don't need to do paravaginal repair along with it, right? So if you suspend the apex clearly at the level of the ischial spine because you've done sacrocolpoplexy, you don't need to do paravaginal repair. So nowadays, the paravaginal repair done vaginally is much significantly lower number of cases done than earlier because the only thing you need is apical suspension. And what you do in paravaginal defect repair, basically, it means that you suspend attaching the pubocervical fascia laterally to the ATFP, right? So how do you do that? 1 second. Yeah. So basically, you have to go very laterally form the, and you have to go laterally till the level of the ischial spine, right? So you actually have to dissect laterally till the level of the ischial spine. So go feel the pubic bone laterally when you're doing the lateral dissection and go to the level of the ischial spine. And once you feel it, you actually have to start taking sutures anterior to it, right? You're going to go anterior to it, take sutures from the ischial spine level all the way to the pubic tubercle along the pubic bone, right? So you're going to feel the pubic bone and go distally, superiorly to the ischial spine. Yeah, so you actually picked up the, here you can see the ischial spine is just distal, and then you picked up the arcus tendinous. It's very difficult to actually see it very clearly in vaginal repair, but if you've gone to the level of ischial spine and gone under only 1 or 2 centimeters anterior to it, you would have gone to the right place. So you're going to go through the arcus tendinous, and then you're going through the vagina, and then you're going to, we normally put stay sutures. So basically you're going to go through the arcus tendinous from the ischial spine level to the pubic tubercle, 3 or 4 stay sutures, and then take them through the pubocervical fascia. This is a very difficult surgery to kind of record because you're going so inside. So you keep going superiorly. I mean, you go anteriorly till the pubic tubercle. You can feel it. Sorry, it's, yeah. So last few slides. So basically, the take-home message is this. Always when you do anti-repair, suspend pubocervical fascia at the apex. When you've got patients with concomitant apical prolapse along with cystocele, repair, also do an apical suspension. We're going to discuss apical suspension in the case-based discussion. Paravaginal defect repair, you don't need to do any more if you're doing a proper apical suspension, because studies show that, right? Now, what are the success rates, right? So earlier, they would only do single compartment approach, so isolated anti-repair, right? And the repair success rates were found to be very, very low, only 30%. So then people started talking of graft augmented repair, right? Putting in a mesh. But even with putting in the mesh, the results were quite poor, right? As low as 30%, 42%, and 46% for anticolporaphy, mesh augmented repair, and paravaginal repair. And so what happened is people actually said our indicators only were wrong, right? So you should not look at only anatomical success rate. You should look at symptoms and anatomical success recurrence, right? So then the measures of failure were revised to symptoms of vaginal prolapse and evidence of anatomical recurrence. And when that was done, when the previous studies of Weber et al. Were reanalyzed, those studies showed poor success rates. They were found to be significantly higher, right? 89%, 91%, and 77% for anticolporaphy, mesh augmented repair, and paravaginal repair. So nowadays, when we look at success, we define it as both symptoms of vaginal prolapse and a recurrence, not purely anatomical recurrence, right? And if you look at the success rates, paravaginal repair is the poorest one, and native tissue repair did actually pretty well, 89%. And since Delancey came out with his descriptions of 3 levels of support, so you have to ensure that your level 2, that is the lateral support, is fused to the level 1 support, like I told you. Long-term evidence also quite encouraging. Very few studies have evaluated the long-term success rate. A 2016 paper looked at 18-year period with a mean follow-up of 5.8 years. They found 7.4% rate of recurrence following isolated anterior compartment prolapse. And most of the recurrence happened after the 1-year point. Although the only thing is, the good point is here is that though 33% of patients with recurrent prolapse required a secondary procedure, only 3.3% of those with isolated recurrent anterior compartment prolapse required a secondary procedure. So that means that native tissue repair of the anterior compartment done properly has reasonable success rates with minimal morbidity. Thank you.
Thank you, ma'am. Excellent presentation. I have a question, ma'am.
Yes.
So, ma'am, if you are using sling with an cystocele repair, is there any change in complication rates?
No, so I'll tell you one thing very importantly, right? And I don't know whether it was discussed earlier. The complication rates are not higher. The thing to do is this, right? Like I told you, always take 2 incisions, don't take a single incision. Second point to remember is this: the cystoscial patients are often Valsalva voiders. Long-standing prolapse, when they have, they tend to be Valsalva voiders. They push to pee because of kinking of the urethra caused by the prolapse. Now, if you do not teach the patient, so whenever I have a patient on prolapse along with SUI and I'm going to do concomitant surgery, I always ensure that I teach them to void without pushing. Because what happens is that they will continue to do Valsalva to void after surgery, even after the repair has been done correctly. What can happen is that can lead to them having voiding dysfunction after surgery. You might think that the sling is tight, but actually it's not the sling that is tight, because they are Valsalva voiders, right? When you push to pee, the sling will obstruct. That's what the sling does, right? It causes dynamic compression. So you also always have to train the patient to void better by not straining, and then do sling surgery along with concomitant prolapse surgery. And if I have a patient who has voiding dysfunction after sling surgery, I will always do ultrasound. So suppose second day they, after surgery, they didn't void well, I would obviously recatheterize, call the patient back on the 5th day, because in the first 72, first week, you can actually go and do sling loosening if the sling is actually tight, right? So on the 5th day, I will actually do an ultrasound. I do transperineal ultrasound or endovaginal ultrasound to see how tight the sling is. If the sling is not tight, it's most likely pelvic dyssynergia. And so you might want to put the patient on CIC for some time, because you see clearly the sling is not tight. And then over time, they will understand how to void without pushing, because you put them on biofeedback therapy. And then they get better.
Okay, thank you very much, ma'am.
Yeah, I have a question, Dr. Aparna.
Yes. Yes.
Actually, many normal females are also Valsalva voiders, and they just void by abdominal pressure, and very little bladder contractions. The uterus contractions have very low pressures, and they just void by abdominal compression. Very many normal females also, they have learnt it like that. What is your take on that?
So most women actually void by, when you say that they don't have detrusor contraction, most women will void by pelvic relaxation actually. Right? It's the basic way a woman voids pelvic relaxation, little bit of detrusor contraction, right? Sometimes they void so well, especially SUI patients, they just release the pelvic floor so well, because anyway the sphincter is deficient. I mean, they have intrinsic sphincter deficiency oftentimes. And as Dr. Rishi Nair said, that they're never mutually exclusive, right? Hypermobility and sphincter deficiency, right? So often, they will just relax the pelvic floor so easily that you won't see any contraction of bladder on urodynamics, right? Now, the point is this, that a normal woman who's voiding by straining, right, can be taught to void by purely improving a pelvic relaxation without doing straining. And I do that in my biofeedback techniques, because if a woman continues to void by straining, she's going to have obstruction post-surgery.
Yes.
And I would also prefer to put a transobturator over retropubic in such patients.
Yeah. Another question, when you are approximating the pubocervicals, is there any point in putting some mesh under it? Is there any benefit?
No. I showed you the evidence. If you do the anti-repair very properly, see, you don't need mesh at all, right? Mesh obviously fall into disrepute. FDA regulations in US are pretty clear about it. So they're banned internationally, right, for prolapse. So don't need to put mesh. Like I told you, follow these principles. When you're doing anterior vaginal repair, go till the pubic bone, really find the pubocervical fascia very, very well. Your last suture should be a permanent suture suspending the pubocervical fascia to the apex. The apex can be cervix, apex can be the vault with plicated uterosacral ligaments from before, or the apex can be the cardinal ligaments during hysterectomy. But always do that step. Never leave a gap.
Good. Yeah. Thank you very much.
So we can move to the next presentation now. Dr. Deepak Dubey. Ma'am, can you please stop sharing?
Yeah.
Deepak sir. Yeah, okay.
Hello, good afternoon, everybody. Is my slide visible?
Yes, sir.
So I'm going to talk about the minimally invasive abdominal approaches for treatment of pelvic organ prolapse. I just want to highlight again what Dr. Aparna said about the importance of the apical support in prolapse surgery. Over the years, and what she said very correctly was, it was felt that the native tissues are weak. That's why native tissues fail and recurrence is high when you use native tissue. But it is now become evident that it is not the native tissue problem. It is the level of support that you have provided. If you just do a level 2 repair and don't take care of the apex, even if the native tissue repair are used, they'll fail. Or even if meshes are used, they'll fail. So you have to address the apical support. So, these are a few slides which indicate to us how important the apical support is in anterior vaginal wall prolapse and almost all forms of prolapse. So advanced anterior vaginal wall prolapse is highly correlated with apical prolapse and usually require a concomitant repair of the apex. Predictive value of a cystocele for concomitant vaginal apical prolapse. As the grade of the stage of the cystocele increases, the predictive value of apical prolapse also increases. And surgeons contemplating cystocele repair should have a high suspicion of vaginal apical prolapse and consider a concomitant repair. So this is just a reiteration of what Aparna said, that you very rarely get isolated defects. You most of the times will have a concomitant apical defect as well. So that is the kind of concept that we need to reinforce amongst surgeons and clinicians who are treating vaginal wall prolapse. So again, as she mentioned, the conventional classifications of cystoceles as either lateral or central, the lateral cystocele was considered to be paravaginal defects, but that alone doesn't seem to be behind the etiopathology. An apical component in cystocele is very common, although often unrecognized. So essentially, before we get into any surgical management, thorough knowledge of the female pelvic anatomy is very important to know, and knowledge and skills to assess and treat functional outcomes. I see many of our trainees and others who get into treatment of prolapse and incontinence. They feel that just doing that procedure, it looks appealing when you do the procedure, but treatment of the functional outcomes and complications of the procedure is also very, very important, that you should not venture into doing these treatments until you can take care of the complications. And unfortunately, as things stand in this country, most gynecologists, at least the ones that I have interacted with in my hospital and nearby, are not that adeptly trained in female urology. And the same applies to urologists who have a very limited exposure to urogynecology during their training periods. And then they can pick up those skills and knowledge by doing fellowships. But I see many urologists venturing into this area without adequate understanding of the subject and the functional outcomes. So coming to minimally invasive procedures, Aparna highlighted how one can provide apical support by the vaginal approach, and I'll be talking about how we provide apical support by the abdominal approach. So this can be applied in various case scenarios: walled prolapse, uterovaginal prolapse when a concomitant hysterectomy is required. If the lady is sexually active and she wants to preserve the uterus, you can do sacrohysteropexy. And even large cystoceles can be approached by this sort of approach. So I will show certain critical operative steps for either laparoscopic or robotic approaches for the anterior vaginal prolapse. The first one will be walled prolapse for sacrocolpopexy, and the second one will be uterine preserving hysteropexy for ladies who want to preserve the uterus, who are sexually active, and you can provide very good apical support by these techniques. We'll just move on to the... Yeah, so this is essentially sacrocolpopexy, where you are, for walled prolapse, where you are providing support to both the apex directly to the sacral promontory. So these are mesh procedures where the mesh is inserted between the bladder and the vagina, and posteriorly between the vagina and the rectum, and then it is hitched up to the anterior longitudinal ligament. So this has shown to provide excellent apical support with good long-term success rates. So this is a video of the laparoscopic sacrocolpopexy, which is like the port placement is like any other pelvic floor surgery. The initial step that we do is we detach the pelvic peritoneum over the iliac vessels and identify the sacral promontory and create the presacral space. So on the left side, you have the sigmoid mesentery. On the right side, you have the iliac vessels and the ureter. You should be careful of the ureter when you're doing this step, because if it is too medial, then you might injure that. You identify the sacral promontory, and then you create the presacral space. The manipulator is then inserted into the vagina, and the bladder is, the anterior dissection is performed, wherein you dissect off the anterior vaginal wall from the bladder. Important aspect is that one should keep adequate thickness of the anterior vaginal wall and not make it too thin. Otherwise, then you can have issues of mesh erosion and exposure. Also, this is a step where sometimes the bladder can get injured and you might open the bladder. So now, following the anterior vaginal wall dissection, we do the posterior dissection. Patients who have had a previous hysterectomy will have invariably a lot of adhesions in this area. So, but otherwise, there are no other important structures in this area. So one should get into the correct plane. Your retractor acts as a guide for you, and you can, when you do it laparoscopically, you can actually have a tactile sensation and know where your vaginal wall is. Once the dissection is complete, we use macroporous polypropylene mesh, which is shown to be very versatile. It does not, incidence of infections is much lower when you use a macroporous polypropylene mesh. We create a Y-shaped mesh after measuring the anterior sort of dissection and the posterior dissection. And we trim the mesh. We don't use a sort of prepared vaginal mesh. We fashion it out like this. And this is the straight Y limb, which will be then attached to the anterior and vaginal wall sort of mesh placement. So we suture this with the interrupted proline sutures, and then this is then inserted into the abdomen. The length of the anterior and vaginal and posterior vaginal length of the mesh is dependent upon the degree of defect that you have identified. The mesh is inserted internally. We start off with suturing the posterior limb of the mesh initially, and then we do the anterior limb. So this goes right down. In a case of wall prolapse, should ideally go down till you identify the levators on either side. And interrupted ethibond sutures are used. They are very good suture material, very strong, and just like any other mesh placement. The important technical point here is do not take too deep sutures through the vaginal wall. You do not want to go through the mucosa. So it's only the adventitia that you take. So that, again, these are the steps that you do to avoid mesh erosion. About 6 to 8 interrupted ethibond sutures are taken. So that provides adequate fixation of the posterior limb of the mesh. And then a similar thing is done. So you need to use a 30 up telescope for this maneuver. If you use 0 degree or 30 down, then it is very difficult to visualize correct placement of the mesh. So with a robot, it's very easy. But if you're doing it by laparoscopy, you can use a 30 down lens and turn it upside down, so you get exposure. These are the sutures, again, interrupted sutures taken through the anterior vaginal wall. And once this is done, then the Y limb is then hitched onto the sacral promontory. That provides good fix. So that is another very important sort of step of the procedure, is the adequate fixation to the promontory. There are some presacral vessels in this area, and one has to be careful. Here we are using bone tackers to fix the mesh. It should not be placed too tightly because that increases the incidence of post-operative pain. And it is hitched on here to the promontory. It's not too tight. You just ascertain the sort of laxity of that, and that is sufficient. The extra mesh is then excised. And after that, the pelvic peritoneum is closed so that we retroperitonealize the mesh. Important part is that no aspect of the mesh should be freely exposed into the peritoneal cavity. Otherwise, there is a chance of bowel adhesions and other kind of complications. So this is final closure of the peritoneum, and the mesh is completely retroperitonealized. So it's quite a clean procedure. And the next aspect is when the uterus preserving for uterovaginal prolapse, when you want to preserve the uterus, especially in young sexually active women who have second-degree UV prolapse. Here, the mesh is sutured from the posterior aspect of the uterus to the sacral promontory. So again, you are providing very good apical support here. Avoiding hysterectomy decreases the risk of mesh erosion. So that's the uterus. And then initially we do a posterior peritoneal dissection behind the uterus. So you just create space between the peritoneum, posterior fold of the peritoneum and the uterus. And you go right down till the cervix posteriorly. So once this is done, then we go anteriorly and open the peritoneum over the broad ligament. So this is an avascular area where the broad ligament is open. You don't have any important vessels in this area. And this is done on either side. The peritoneum over the cervico-uterine junction is also open. And that's the anterior cervix, the bladder, and the uterus. And that's the anterior vaginal wall. You can even extend the mesh to the anterior vaginal wall if you want to. Here, the mesh is slightly different. It's a T-shaped mesh, again made out of macroporous polypropylene. So the two limbs of the T are then brought around the broad ligament anteriorly with the peritoneal window that has been opened. This is sutured to, this is essentially over the cervico-uterine junction. This is the posterior aspect of the mesh, which is again, few sutures are taken behind the uterus. And then the mesh is then again similarly brought to the sacral promontory. So you can provide adequate fixation here, and similar to the technique we saw for the sacrocolpopexy for walled prolapse. But this is uterine preserving, and again, the closure of the peritoneum. So you can also, if necessary, if you can do a supracervical hysterectomy here, if a hysterectomy is required. Here, what happens is that's the anterior vaginal wall, and this is the cervix. So when an abdominal approach is done for sacrocolpopexy, and you're going to do a hysterectomy, then it's better to do a supracervical hysterectomy after ascertaining that there is no, the pap smear has been done, there is no disease in the cervix. Because if you cut off the vaginal wall, suture it, and then apply the mesh, then the chances of mesh erosion are higher. So this is closure of the cervix. And finally, you place the meshes both posteriorly and anteriorly. So that's kind of most about the abdominal approaches, we have not found any real difference between using a robotic approach or a laparoscopic approach. I think many surgeons with advanced laparoscopic skills can do this procedure without requiring the use of the robot, but definitely having a robot makes the job a lot easier. So I think I'll probably we have an experience of by these techniques of now about 120 patients, and we have a median follow-up of about 5.5 years, which is a very long follow-up. We have had 2 patients who came back with mesh exposure, mainly in the anterior vaginal wall. And both those patients, the mesh was trimmed and the vagina was closed over it, and they did not have any recurrence. So we have not had any serious complications aside from 2 mesh exposures. And symptomatically, we have had very few incidents of recurrence. Sometimes they have complained of a little bulge, but not requiring any further procedure. So thank you very much. And yeah, that's all I have to say. Thank you.
I had a technical question to ask you, sir.
Yeah.
So when you're doing the opening the presacral peritoneal fold over the sacral promontory, right? S1.
Yeah.
Why do you want to go so laterally? Why can't you just what we do is retract the bowel very nicely, and then when you put it on stretch. When you put on the stretch, you can actually open the peritoneum directly on the promontory, right? You don't have to go
actually, that's
laterally
exactly
and
what
all the
we
way
do.
down.
What you described, when you can retract the sigmoid mesentery on your left, and once you provide
Yes.
good traction,
Yes.
that peritoneum over the promontory is very thin, and you can
Yes.
directly get access there. I agree with you.
Second point I want to make, sir, is that you showed that you put the mesh, suspended the mesh to the sacrum, and then you close the peritoneum over the mesh. But what we find is that, and even literature talks about it, is that in fact what happens is that once you suspend the mesh to the sacral promontory S1, problem is that closing the peritoneum over the vaginal end of the mesh can become quite difficult sometimes, because you don't have that much peritoneum to play with. So what we tend to do is we put the Y-shaped mesh on the anteposterior vaginal walls, then close the peritoneum over it, and then you suspend to the mesh to the sacrum, and then you close the peritoneum over the remaining part of the mesh.
I think I'll try that the next time. I'll see. You're right that sometimes once you do this, it is a bit of a struggle to close the peritoneum.
Yes.
But certainly your point is well taken. We can do that and see whether that is
It becomes
easier.
very easy, sir, because sometimes you're putting the posterior peritoneum very low down, you don't have that much, and then you don't have much to play with, and it becomes a real struggle. Right? So.
Agreed.
And one more point, sir, this is a point we discussed much earlier. You're very right that you can go actually to the perineal body, and you need to go till 1 to 2 centimeter up to the bladder trigone, just above the bladder trigone, right?
Yeah.
You can go that down. Yeah.
Okay. So we'll move on to the last session of the day, which is the case-based discussion being moderated by Dr. Aparna.
Yes.
And we have Dr. Deepak, Dr. Shrikala Prasad, Dr. Vikram Shah Batra, and Devendra Sharma, and Dr. Pradeep Sharma.
Yes. So yeah.
And maybe all those who are present, if they have a question, they can please chip in between either through the chat box or directly. Yeah. Please go ahead.
So what I've done, since I've only got half an hour, what I've done is that it is very given different POPQ scenarios. And I'm going to ask, what will you do in this particular case, right? So we discussed this, right? That apical support is very important. Cystocele never happens independently. It always, oftentimes happens along with multi-compartment prolapse. So when you have a patient with cystocele along with SUI, you are also dealing with multi-compartment prolapse. So when will you do which repair is always a conundrum. And we talked about the fact that if you have apical prolapse concomitant, you have to do apical suspension. I showed you vaginal technique of anti-repair, but I did not show you vaginal technique of apical suspension, right? The vaginal technique of apical suspension would be sacrospinous ligament fixation or high iliosacral ligament suspension, right? Because of lack of time, there was no time to show that. It was showing you cystocele repair. But some other day I can show you those repairs also. But let us discuss when to do what, right? When should you do laparoscopic or robotic hystropexy or sacrocolpopexy, and when should you do the vaginal approaches, right? So let's go. So what I'm going to ask the participants, panelists, is to clearly keep your answers short. We only got half an hour. I'm going to ask you which surgery you will prefer in the particular scenario, and just keep it short to one line, right? So now this is a patient POPQ. If you, Dr. Srikala Prasad, can you very briefly describe the POPQ? Very briefly. Can you all panelists actually unmute yourselves? Srikala Prasad, ma'am, you're unmuted. So just to save time. Can you all unmute yourself?
Yes, ma'am,
okay.
Unmuted.
Yeah, Dr. Srikala Prasad having some problems. So I'll just tell you, this is stage 2. If you see the POPQ 0, 0. So we have a grid like this, right? The first row is the row of, so you can clearly see 0, 0. So this is stage 2 anterior wall prolapse. So what will you do in this case, right? Now I'm going to give you different scenarios. So if a patient has concomitant SUI, would you prefer concomitant sling surgery? Suppose this is a frank concomitant SUI. Dr. Deepak Dubey?
If the patient has a concomitant SUI, which is manifest, I will definitely take up for a concomitant sling surgery.
Okay, you answered it. So I'm going to ask the next question, Dr. Deepak Dubey. If the patient has occult SUI, would you offer concomitant sling surgery?
I would certainly counsel the patient that there is a very high chance that she would land up with stress incontinence if I would not address this, and I would be more inclined to do a sling along with the prolapse surgery with occult SUI.
So would you offer the patient a choice, two-step procedure or
I
single?
would offer the patient a choice. Certainly, I would offer the patient a choice. What I have observed, Aparna, is many of our patients, I mean, at least the type of patients that we get here, they want everything fixed in one go. They don't want to take a chance. The whole what you can say, the coming back to for another procedure, they're most of the times not willing. Very rarely do I find people who are ready to take that option.
Absolutely.
Earlier, I always used to tell I will do it together. Now I give them a choice. Yeah, it can be done. It avoids another surgery. But if you want to take a staged repair, there are some who don't require. So I tell, but many of them do require. So you take the chance. Earlier, I always used to say, yeah, good, I will do it together. And honestly speaking, I've never had any complications. But because the guidelines keep telling, there is an increased adverse effects and side effects, I now tell a staged.
Absolutely. Let's look at the evidence after this. I'm going to ask a third question, and then I'm going to look at the evidence, right? Dr. Batra, if the patient has no SUI or occult SUI, right? What would you counsel the patient? Like, patient has come to you, cystocele, you've done everything. What will you counsel about SUI post-surgery?
Ma'am, as well as SUI, as well as urgency incontinence is also likely in this scenario. And most of this SUI, which is not occult and which is not manifest, can be managed conservatively or by medication. But there is a rare chance.
No. The question is this. Cystocele, you try to elicit occult SUI. She's got no concomitant SUI. There is no occult SUI seen on examination. What will you counsel the patient? It's an important point to tell the patient.
I will not do an SUI surgery for her.
Absolutely. But what will you counsel the patient? Is there any particular point that you need to tell the patient?
With respect to continence or with respect to the overall success of the surgery?
Continence. This is continence question. Suppose you've got a patient
resolution of cystocele and with no manifest or occult incontinence, there is less than 5% chance that she'll have an incontinence later in the post-operative period. Although if there is any, she would need rehabilitation, both pelvic floor muscle rehabilitation, maybe perineal ultrasound guided if there is required, but she may land up in an SUI. There is not a 0% chance, but she'll need continuous support from urology perspective. That would be my counseling.
So let's look at the evidence. The evidence very clear. If you have concomitant SUI and prolapse, you may, it's very, going into concomitant procedure may be a good idea because the SUI is not going to improve. It may even worsen after prolapse surgery. So concomitant surgery may be ideal for those who come with symptomatic SUI along with pelvic organ prolapse. If they come with occult SUI, then two-step procedure may be something that you want to offer the patient. You should leave the choice to the patient, whether they want single procedure or two-step procedure, because they may have mesh complication later on, right? So what you should tell the patient is that she may have post-operative symptomatic SUI, but it may not happen in every patient. So the choice is left to her. Third point is about patient in whom you've not demonstrated occult SUI. You've really tried, but you don't get occult SUI. The problem is that actually rate of post-operative SUI is very high. It's almost 39% in CARE trial. And if you look at the in 38% in OPUS trial. So the rates are not 5%, it's actually 39%, 38%. So whenever you have a patient in whom she's got cystocele and there is no occult SUI demonstrated, tell the patient that no matter what I do, I will not be able to elicit occult SUI very well, because when you cough during examination, again, the urethra can get kinked. So 39% can still get SUI post-surgery, but you'll manage it if that happens later on. But right now I'm not going to do sling surgery because I've not seen any SUI.
I think
So
you have
always tell the patient.
important thing that counseling is critical, because you do a good prolapse repair and then they come back with SUI and they think that you have done something wrong with them.
Absolutely. The rates are very high, 39%. This is one important take-home message. Always counsel the patient that I'm not doing sling surgery, but you may get it later on, right? Because you can't elicit occult SUI very well. So this is first scenario, right? The second scenario, quickly, Dr. Srikala Prasad, very quickly describe this POPQ, because you trained them in POPQ. So just wanted to kind of...
See, here you are having a good vaginal length, but you can see the anteriorly also there is a descent. The point A is also above. Again, posteriorly also it has come up. You can see the cervix and the D point also. So there is a perfect descent. So, but it is still stage 3 because the total vaginal length is only 10 centimeter. However, it is better to do along with the vaginal hysterectomy. It is better to do an apical suspension. Only then we will be able to cure her.
Ma'am, this is stage 4, right? If you look at the C point, it's plus 9. So stage 4.
9. More the TVL minus 2. Yes.
Yeah. So we use, so basically,
if it is more than 8 itself, it is stage 4. So definitely you have to do a apical suspension. I would prefer a sacrospinous scalpel suspension.
No. Wait on this, ma'am. Wait on this. I'll go through the scenarios. And just start toning what I've asked. So basically, it is stage 4, because if you look at total vaginal length is 10. And if you look at C point, it's plus 9. So it's only 1 centimeter less, right, than vaginal length. So if it's less than 2 centimeters, then it will be stage 3. If it is more than 2 centimeters, less than 2 centimeters, it is stage 4, right? So this is stage 4 walled prolapse along with concomitant stage 3 anterior posterior walled prolapse. So let us go through different scenarios, right? If the patient was sexually active, so let's go through if a woman is sexually active, postmenopausal woman, and she's not interested in uterine.
It's not a vault prolapse, no. You've written D measurement. You've written D measurement. Just go through.
D is also hollow, right? D is also gone down, right? This is actually even the posterior wall prolapse.
So it's not a vault prolapse. It's a pelvic organ. It's not a vault prolapse.
It's apical prolapse. It's got uterine. Everything is. It's actually, if you look at the D point, it's plus 7, ma'am. Right. So
no, ma. If it's a vault prolapse, we don't mark D. We put a dash.
No, it's not a vault. This uterus is in place, ma'am.
No. In between, you told vault. That is why I asked.
No. The word apical.
Okay, so fine.
This is basically a patient who's got uterus in place and her apex is descended plus 7. D point is plus 7. C is plus 9. Okay, clear. Now let's go through different scenarios, right? Dr. Sharma, which is Dr. Pradeep Sharma, sexually active postmenopausal women, and she's not interested in uterine preservation. What will you do? What surgery will you do? Cystocele along with uterine prolapse. This is stage 4. Dr. Pradeep Sharma is there, or Dr. Devendra Sharma? Hello? Can they hear me?
I don't think so. They are there, ma'am.
Okay, then I'm going to keep it to Dr. Deepak Dubey and Dr. Batra and Dr. Shrikala Prasad. Dr. Deepak Dubey, what will you do here?
Yeah, I
Sexually
mean, if
active woman,
she's not
not interested
interested
in preservation. Yeah.
uterine preservation, then I will do I mean, it's the best thing would be a vaginal hysterectomy and an apical suspension. A sacrospinous suspension will serve her well.
Yes. So basically, you can
I'll add a sling to it. I'll likely add a sling to it also, ma'am.
Why?
Yes, ma'am.
Why?
Sister seal and a rectus seal repair.
No, no need, no need. In
No
fact,
need at
we
all.
don't put in a mesh
Yes.
when we are doing it
Yes.
from Bigo. The guidelines clearly forbid the use of mesh in pelvic organ prolapse
Absolutely.
when done vaginally. When you're doing it
Absolutely.
laparoscopically or lobotically, you can put in a mesh. But when you're doing it from below, it is only native tissue repair.
Absolutely, Dr. Shrikala Prasad. Whenever you do vaginal surgery, never put in a mesh. You can do vaginal hysterectomy with AP repair with perineoplasty. One important take-home message, right? Always do perineoplasty, right? Not just vaginal hysterectomy and anterior-posterior repair. Along with apical suspension, you need to also have perineoplasty because there is enough evidence which says that if a genital hiatus is widened, you can have increased chance of recurrence, right? So wall suspension, which can be either hiatus sacral ligament suspension or sacrospinal ligament fixation, along with AP repair with perineoplasty. Okay, never, especially Dr. Deepak Dubey, even when we're doing this one point, right? When we do even apical surgery using, robotic or laparoscopic hysteropexy, sacrocolpoplexy, always go in and narrow the genital hiatus. Very important take-home message.
I just wanted to, yes, this is the point I wanted to add.
Yeah, I'm going to come to this. Sexually inactive postmenopausal women, Dr. Shrikala Prasad?
See, you are trying to tempt me to say colpoclysis. But then, because of that word sexually inactive postmenopausal women, you're trying to tempt me to say colpoclysis. But I have seen in my practice where colpoclysis has been done in spite of an adequate cervical screening, endometrial screening, patient come with late stages. So in our country, given the very high incidence of cervical and endometrial screening, cancers and the very, very bad follow-up, I will never advocate colpoclysis in a woman with the uterus. If it is a stage 4 vault prolapse, sexually inactive, I would maybe do a colpoclysis. But if it is a woman with the uterus, I am very much against retaining the uterus. So I will still vote for not a Leaford colpoclysis, but I will do in India. In India, I would definitely not go because
I would love you to publish this evidence, madam, because if you look at international evidence, it's on our own paper from my training days, 325 patients over 10 years, none of them developed. So you have to choose the right patient, right? If you look at cervical cancer, it is the age group also, right? If you have an older woman, postmenopausal, around 70, 75 and above, the chance of cervical cancer after that, I think it will be good to publish your evidence, ma'am. Because if you look at evidence, it clearly is for Leopard colpoclysis because 98.1% success rate, even anatomical, right?
No, the points which I differ are, one thing is most of us vaginal surgeons are able to do a hysterectomy in a very, maybe 15-20 minutes, we're able to do a hysterectomy. So I would, if you see, the numbers really don't matter. If you see a case with late malignancy, because our country is very famous for a
Please,
low
ma'am, let's
follow-up.
go on the next point. You made your point, but I would love you to publish this evidence, madam. It's very important because if that is your experience, do publish it.
Your paper was in India or was in abroad, Aparna? Your evidence?
This is an abroad paper. Do publish your evidence, is what I'm trying to say. Because if you found this, it should be, because internationally, this is what they say. But I agree with you. You can choose a hysterectomy over this, Leopard colpoclysis, and give that choice to the patient, right? Now, let's go to the next scenario. I've got a lot of scenarios, madam. So let's go to the next.
Okay.
Yeah, if it's a premenopausal woman and she wants to preserve the uterus, I'm going to come to Dr. Deepak Dubey. Premenopausal woman wants to preserve uterus. What will you do? Will you do surgery or in that patient, or you will do a uterus in place?
Yeah, I would do a laparoscopic hysteropexy in this patient if she is sexually active, obviously premenopausal. I think that would give her a better outcome from all aspects, cure of the prolapse and maintaining a sexually active life.
Yes. So to answer the question that was asked in the chatbot, this is one indication where you are very right. You can do a laparoscopic sacrohysteropexy. Dr. Srikala Prasad, what would you do in this place? Because you're a vaginal surgeon. What would you do in this place?
I will do a vaginal sacrohysteropexy.
Sacrohysteropexy or a sacrospinous ligament fixation?
Sacrospinous ligament hysteropexy.
Yeah. No. So be very careful.
See,
it'll be sacrospinous
See, the
ligament,
thing is,
not
I do even a modified for the gills, and then I modify it by taking a bite on the sacrospinous ligament and fixing it to the neocervix.
Okay, so basically the difference here is that in vaginal you're fixing to sacrospinous ligament and laparoscopically you're going to the sacral promontory. Right. Now the evidence is this. Again, Dr. Deepak Dupe, perinoplasty, very important when you're doing laparoscopically. No matter what you do laparoscopically, go in and narrow the genital hiatus because the failure rates can be very high. And that's one thing I keep noticing even after gynac surgeries, where when they're doing it laparoscopically, they never go to the perineum and do perinoplasty. Always do it. Right. So you are very right. At the 12-month point, you can do either, right? The success rates are equivalent between Dr. Deepak Dube's choice and Srikala Prasad ma'am's choice, right? There were more bothersome symptoms of OAB and fecal incontinence reported after laparoscopic sacrohysteropexy, but that is not linked to the patient. It's the individual patient's issue. And you have less dyspareunia if you do it laparoscopically, right? However, one important take-home message for all the laparoscopic surgeons is that if you have advanced cystocele, right, if your BA point is more than equal to 3, right? So basically what does it mean is that this is a patient who's got BA point very, see, if you see how this patient, the BA point is further down, right? The BA point is +7. So the point to remember is this, if the BA point is more than 3, it's linked to surgical failure, independent related surgical failure. So here you have to be very, very careful that you have to go all the way to the, just within the trigone. So how low do you go, Dr. Deepak Dubey, when you're doing level 2 through the laparoscope?
Very valid point. Recurrence following laparoscopic procedures has been shown. I mean, there is data showing now that each centimeter of you go higher up with the mesh, the incidence of anterior vaginal prolapse in follow-up increases. So for each centimeter above the trigone, you have a higher chance. So I think if you have a BA point which is so low, it is imperative that you don't do a half-hearted, if you're doing it laparoscopically, you don't do a half-hearted, anterior vaginal wall sort of mesh. You go as low down as possible, and what is highlighted is go right up to the trigone. Otherwise, the chances of failure are higher.
Absolutely important take-home message, right? One last point, right? If the woman has got concomitant SEO with ISD and the patient wants 2-step procedure, okay, this is a very important question. Dr. Deepak Dubey, because you're the laparoscopic surgeon, I'm going to ask you this. Patient wants 2-step. She's got this kind of prolapse and she's got ISD also. But if she wants to say ISD afterwards, will you do laparoscopic sacrohysteropexy even then? Very important point.
If she has the intrinsic sphincter deficiency, most likely she is going to need a sling later on. And in that situation, then I would counsel her against doing a laparoscopic hysteropexy because.
Why would you do that?
Because it's going to be technically difficult, addressing this afterwards. It will be better if we go by a vaginal approach.
There's another reason for this, Dr. Srikala Prasad.
See, ISD, you want the patient to preserve the uterus as well do treatment for ISD. That is what you are asking, no?
No. I'm just saying this patient is prolapse. I'm not talking about preservation of uterus.
You are not talking.
Along with ISD, okay? It doesn't matter the uterus in place, not in place. You remove the uterus, maybe doing whatever, right?
See, if it is an ISD, 2 things are my choice: a retropubic taping or a pubovaginal sling.
No, ma'am. The question.
No, I don't get your question.
The question is this: sometimes patient want 2-step procedure. Okay. Okay, and the patient has got ISD. She's got concomitant SUI. You've offered her 2-step, and she's taken 2-step, right? She wants 2-step, but she's got ISD. And sometimes it can be very difficult to pick up ISD when you do urodynamics in very large prolapse. It's very hard to do urodynamics. So, but you've done your UCP, found she's got ISD. Would you? Why is it that you would not want to do laparoscopic sacrohysteropexy as the first procedure?
See, I am a good vaginal surgeon, so I'll do a vaginal hysterectomy with the sacrospinous scalpel suspension so that her pelvic organ prolapse, I give a good support. She wouldn't rip an apical prolapse or a vault will not occur. If
No,
she
so the
wants a
question was, the
Ah.
question, sorry to interrupt
You
you here,
give the
ma'am. The
answer.
question
You
is
give the
different.
answer. Aparna, give the answer.
Okay, the answer is this, that, you know, when you do laparoscopic sacrohysteropexy, it pulls the bladder neck to the abdomen, sir. You will find, especially when you go down to the trigone, the bladder neck gets pulled up. If the bladder neck gets pulled up in a patient of ISD, they can have worsening of the SUI. So very careful, you be very careful. If a patient has got ISD, then either you do a single step procedure, you do both together, or you do a vaginal surgery as a first procedure, because you will have worsening of ISD often.
Right.
If the bladder neck is pulled up, right? You agree?
Yes, agree.
Yeah, it's a very important step. I've got multiple patients coming to me after laparoscopic sacrohysteropexy where the ISD is worsened. They get up after surgery and the urine, they just leak like a tap. It's far worse than before because the bladder neck is pulled up and remains open like a coin. Right? So
then
always be very careful.
that kind of situation, in that kind of a situation, if you have to do a sling later on, you feel
Yes.
that's not going to give her a good outcome if you do a sling later on.
Can do a sling later on, but then the patient have a very horrible sequelae afterwards, right? I mean, imagine leaking so badly like a tap because the bladder neck is open, but you can do a tight bladder neck sling, sir. You would put a rectus fascia or you would put in a tight bladder neck because the bladder neck is open. So you want to cause obstruction of the bladder neck now.
Yes.
Just a simple mid-rectal sling, even if retropubic, will not work in such a patient.
Yeah, retropubic sling won't work. Yeah.
Exactly. That's what is the very important point, because a lot of people doing laparoscopic sacro, especially Dr. Gynacs, you would have gynacs doing laparoscopic sacrohysteropexy or laparoscopic sacrocolpoplexy, but they have not looked out for occult SUR or SUI, right? And sometimes even ISD can be masked by very severe prolapse. So this is a very important take-home message if you've been called in for such a patient. Okay, now next scenario. Right? Now this is a patient. Look at this. Again, Dr. Srikala Prasad, you want to talk about the very short, in short, your prolapse findings?
Just 5 minutes, please.
Yeah. Okay. Then let's go again because I've got two more scenarios. This is stage 3 anterior prolapse and stage 2 wall prolapse, right? Uterine prolapse, sorry. Right? So now you have this kind of case. Postmenopausal woman does not want to preserve the uterus. What will you do? If you have, the question is this, if you got stage 2 prolapse of the uterus, uterine prolapse stage 2, would you still do apical suspension along with cystocele repair?
If the cystocele is large, yes.
Yes, very important take-home message. Yeah, exactly. If you have a patient who's got very large cystocele, even if you've done vaginal hysterectomy, please go ahead and do a
apical suspension.
Also. Exactly, and that can be either high uterosacral ligament suspension or sacrospinal ligament suspension. Now, the evidence is clear, both are equivalent. However, the problem is this, when you do sacrospinal ligament fixation, you can have increased chance of recurrence of cystocele. So one more important point is this, right? If you have high-grade cystocele, you might want to do high uterosacral ligament suspension over sacrospinal ligament fixation, right? Keeping in mind it's got higher rate of ureteric injury. Why? Because in
always
sacrospinal
follow up with the cystoscopy.
Yes.
Now I accept what you're saying. My question, Aparna, is now suppose as a urologist, I feel this patient one point I want to highlight for the benefit of this doing a hysterectomy, is it like, how do we address this with the patient? Do we ask them, do you want your uterus out, provided we make sure that there's no disease in the uterus? Like many times what I is many patients post-menopausal, they are reluctant to have their uterus removed unless as a surgeon you force them.
No, never. As a urogynecologist, we offer the choice to the woman. Even if she has got uterine prolapse, she is the one who chooses her goals in life. She does not, the question is, does not want to preserve the uterus. I'm going to come to
I think I want to highlight this because when I see, the standard practice, at least with gynecology here, is post-menopausal, remove uterus. Post-menopausal.
That's the question, sir. I've come to this. Is vaginal hysterectomy always the answer? This is the question I've asked. You're very right. In fact, the evidence is that at the 5-year point, sacrospinous hysteropexy actually has equivalent results. And I would say the same for laparoscopic hysteropexy.
Yes,
right?
yes.
So No, this is a very valid point that in India, people are just dying to remove the uterus. Give the choice to the patient. This is precisely the question I have, the next point, right? So remember that if you do not remove the uterus, even if the uterus is at stage 2, it is fine if the woman doesn't want to remove the uterus. It's the woman's choice.
Yes.
And the evidence backs it, right? You agree with me, Dr. Deepak Dubey?
Yes, absolutely. I wanted to highlight, but you already have had it coming. So I think this is an important message that should go across.
Yes, because India is on uterus eradication program.
Yes.
And that is not a good thing to do. A woman's feeling of being femininity is linked to a uterus often. So give
I'll
her
tell
the
you
choice.
why. I'll just quickly tell you why. Because there's a lady who came to me and she had seen a gynecologist, and she said the gynecologist is insisting on removing the uterus.
Absolutely.
Yeah.
And the evidence is backing it. The 5-year point, the sacrospinous hysterectomy, you can do it vaginally, is equivalent to hysterectomy results. And it would be the same for your laparoscopy. And here you can choose to do it laparoscopically.
Yes,
right?
yes.
It's a premenopausal woman wants to preserve uterus, it's clear, your surgery, laparoscopy, sacrohysterectomy, right? Again, you can also do a sacrospinous. So either your choice, both of your choices are okay, right? Dr. Deepak Dubey's choice and Dr. Shikla Prasad's choice are equivalent, right? Only that perineoplasty needs to be done. Very important take-home message. Now, can I have 5 minutes more, Dr. Nair? Just 5 minutes more.
Quickly, ma'am. Quickly, please. We have already over.
Okay, this is a patient in whom uterus is out. This is vault prolapse. Okay, clearly the vault is out, right? Completely out. This is procedentia. What will you do? Postmenopausal woman, not sexually active.
I will do a colpoclysis.
Yes. So Lefort colpoclysis, exactly, right? Lefort colpoclysis. Postmenopausal woman, sexually active.
Then we can do an apical
Dr. Batra, wait,
Ma'am,
Dr.
apical, vaginal, ma'am, vaginal. I'll proceed vaginally, repair anteriorly, posteriorly, and I'll suspend it vaginally, ma'am. Sacrospinous ligament fixation with wall prolapse. Yes, ma'am.
And most of these vault prolapse have a large enterocoel. And reducing
Yes, ma'am.
that and
It's
repairing
huge. It's huge. Almost like an
huge
incisional
enterocoel.
hernia. A huge one.
It is very good if you repair,
So
site-specific repair is also.
So now, recently, a paper was in 2023. You can do either. You can do laparoscopic sacrocolpoplexy or you can do a vaginal sacrospinal ligament fixation for wall prolapse. Both of them are equally okay, right? Now, the main thing is that if you're doing a primary procedure, maybe a vaginal surgery would be better. For recurrence, 100% laparoscopic sacrocolpoplexy, right? Okay.
Just one.
ma'am, what's the evidence of robotic sacrocolpopexy in this vena recurrence? Do we have an evidence or
there is no evidence comparing robotic and laparoscopy? They go together, right? There's no separate evidence separately for robotic. Okay, now I'm going to ask this Dr. Batra and Dr. Dubey, please answer this. Would you prefer laparoscopic sacrocolpopexy in a post 60 or 65-year-old woman, given that it might take less time to do vaginal surgery in the hands of like Dr. Prasad? I'm sure Dr. Shikla Prasad does it so quickly.
Ma'am, I will prefer vaginal only, ma'am. I would
Exactly.
prefer vaginal only any day, ma'am, because in case of it's a shorter anesthesia time, comorbidity is less, and it's a relatively easier surgery vaginally. You don't go intraperitoneal for something which is completely extraperitoneal.
You're very right. And Dr. Dubey, if you've got a post 60, 65-year-old woman, this is primary, huh? This is primary, huh?
I have ideally, yes, vaginally is the right approach, but my problem has been I have been doing laparoscopic procedures in this particular age group, and simply because of the fact that I do not see a proper, my colleagues in gynecology who half-heartedly, attempt these procedures, they are unable to give unable to give them a good outcome by a good apical suspension transvaginally. That's my only reason, but I totally agree that going transabdominally, giving general anesthesia, pneumoperitoneum, it's better to do this vaginally. I agree with you, but I do these procedures because I'm not very confident that my patients will get a good. I'll probably have to send them to Srikala, but that's a very long way.
And me, I'm just joking.
I know you, of course.
No. One very important take-home message. If it's a primary prolapse, right? It's never operated before, not recurrent, then vaginal surgery is the way to go. But it's a recurrent prolapse. Even if 60, 65-year-old woman, you'll be right. Sir, you're right to do laparoscopic colpopexy in a recurrent prolapse in a 60, 65-year-old. Given that the women are living longer also, right?
Yes.
Because so you are right there. So remember, take home message, recurrent prolapse. So this is, if you see this patient, this is recurrent, correct? This is walled prolapse. In recurrent prolapse, if it's a significant wall prolapse, then you could do a lapsacral polymorphexy. And premenopausal women, of course, the same thing, right?
Yes.
Last scenario. Look at this scenario. Yeah, last slide. Finished.
This is a
Last slides.
so
What is this?
apical prolapse.
Dr. Batra, what do you see
Apical
here?
prolapse.
Huh?
This is an apical prolapse. This is an apical
Yes, but
prolapse.
what is the difference between the two apical prolapses here?
Yeah,
There's
one has a
an
significant
elongation of the cervix, no
cervical.
cystocele.
There is a huge
There is no
vaginal cervical
cystocele. There is an
elongation, and there is no cystocele. Yes. So I think
Yes. So
if she is
basically,
a postmenopausal female, I would, and she is willing to, she's not sexually active, willing for removal of uterus, I would proceed with hysterectomy and obviously sacral spinous ligament suspension.
you would do either of the two cases? Like if you have cervical elongation, also you would do hysterectomy and sacrospinal ligament fixation?
So if she's willing, yes, if she's willing.
Dr.
The patient is willing.
See here, actually, if you see the point D, it will be well supported.
Yes.
There is an elongation only.
Yes.
So that is what I want to say. Point D will be good. It's an elongation. There is no suspension failure in these patients.
Absolutely. So one important take-home message for urologists: not all cervix descending is apical prolapse, right? Here, if you look at the right image, the cervix is elongated, but the apex point D is very well supported. In such a patient, you want to do a Manchester Fothergill surgery, right? Where you are actually cutting off the excess cervix and you're suspending the apex, right? So this is what you don't need to do. Both are not similar. If you look at the image on the left, this is a classical uterine prolapse. And in here, you would do hysterectomy and whatever you spoke about already. But on the right side, this is basically cervical elongation. And here, you don't want to actually do a hysterectomy because you are actually going to cut good support. So do a Manchester Fothergill surgery, right? Can I have one more last slide or is it finished?
Aparna, I have to leave. So you can check with them. I mean,
yes.
One last, Dr. Deepak Dubey, one last thing you see this. I want to show you this.
Okay.
Cystocele along with sling surgery, right? Patient underwent cystocele with transabdominal sling surgery and then came with obstructive symptoms. And this is a woman who gave a history of Valsalva pre-void, right? See, voiding by Valsalva pre-op. This is what happened. Just wanted to show you all. Oh, the video is not working. Anyway. For some reason, video is not working. So basically, you can clearly see that the patient is Valsalva void. Sorry, I'll have to find the video then. It's okay. This video didn't work. So
Thank you so much, ma'am. You very eloquently brought out all the issues that are related with the treatment of cystocele prolapse and the associated incontinence. We come to the close of today's webinar, but before we close, I would like to have a few comments from Dr. Ramesh Sethia, who is the Secretary of the Rajasthan Urology Society. Dr. Ramesh.
Yes, sir. Good morning, good afternoon to everybody. And I am really thankful to North Zone Council and Dr. Rishi particularly, giving Rajasthan this particular opportunity. And we are on behalf of Rajasthan Urological Society. I am thankful to all faculties, those who have taken out their time from their busy schedule, particularly on Sunday. And I'm sure the audience will be benefited from the discussions, healthy discussions we had, because this is the topic which is very less discussed, and even we practice more or less. So I'm sure that this will help us in improving our urogynecology knowledge and addressing this particular problem in 50% of the population, which is not, at present we are not looking at. Thank you again to all the participants and faculties. Thank you, ma'am. Thank you very much.
Thank you.
Thank you.
So as it is evident that all speakers and the faculties did very well, they presented very nice and elaborative and practically relevant. So it was very enriching webinar, and thanks North Zone and thanks RUS Royal Urological Society of Rajasthan, for giving the platform and making me, to organize this or convene this webinar. And thank you all again. Thank you all participants, faculty, and everyone. Thank you.
Okay, so from the North Zone side also, I would once again reiterate our respect for all the faculty who joined us today. On actually, we have a heat wave going on in entire North Zone, and we were able to join in and discuss the academics through the comfort of our own homes. So once again, thank you very much. We'll come back again maybe in 2-3 months with some similar kind of activity, and hopefully we would see you all together. And before we go, there is one announcement. We have a physical workshop of North Zone coming up in Jalandhar on 20 and 21st of July. So I invite all of you to please come there, and we are going to discuss about the BPH 360 degree. All aspects of the BPH are going to be discussed at that time. So please welcome there. We are eager to see you physically there. Thank you very much. Good afternoon. Thank you.
Thank you. Thank you very much.
Thank you. Thank you.
Thank you.